All right, you can start now, ma'am.
Okay. Good morning, friends. I welcome you on behalf of Indian Medical Association CGP Sub-Faculty Mumbai branch. Today we have got a multi-speciality CME. We have got a galaxies of the speakers who will impart us we will impart us their knowledge with us and the line of treatment and the latest mode of treatment they share with us. Today is an auspicious day of Raksha Bandhan. Even if everybody has attended the program, I thanks everybody for attending and sparing their Sunday morning time. Now we'll start with, I'll request our president, Dr. Jitesh Mehta, to give a presidential and giving the upcoming events of our branch. Over to Dr. Jitesh Mehta.
Thank you, Dr. Usha Shah. And good morning, friends. Good morning to all. On behalf of IMA Mumbai branch, I welcome you all and wishing you a very, very happy Raksha Bandhan today. I'm sure all the sisters are very excited to meet their brothers, either Rakis. And I think this is one occasion where one of the first after the lockdown where I think people are meeting each other and a very legitimate excuse to meet each other. Friends, IMA Mumbai branch has got a lot of activities coming up. The very next Sunday, we have got a eye camp, which is being held every year by none other than Dr. Arjun Ahuja, who is the head of the ophthalmology, the ophthalm committee of IMA. We shall be having the eye camp where patients are seen and cataract surgeries will be done at whatever lowest cost that can be incurred. After that, we have got, of course, September month. I mean, after this, all celebrations, festivals have started. So we'll be having a lot of festivals, but even then, we are going to have our CMEs because there are days coming like Alzheimer's Day, Heart Day, World Heart Day, World Alzheimer's Day. So we will be having programs on those days because, as you know, medical science is progressing at leaps and bounds, and we always need to keep ourselves updated. And sitting at home and doing webinar, I think, is the most convenient way of updating ourselves and seeing each other on the screen, nevertheless, not in person. So those are the programs coming in the next month. You will be informed about that. Friends, I just want to mention that Indian Medical Association membership is a very important factor that we need to look into. The number of members, the ratio of the members of IMA overall, all over India, not only in Mumbai, is very less compared to the number of doctors that are practicing all over India. So that is one thing that really needs to be done. We all must always keep in mind that we have to make people new members and motivate them and make them aware of Indian Medical Association strength. You must have seen in the last few months so much of turmoil happening, and IMA all over the country stood up and in one voice fought all the problems that came on the IMA, on the medical fraternity. And we have been successful in so many things. Slowly we have been out of the Consumer Protection Act, and then now some new rules have come that even in the criminal court, the doctors cannot be just pulled up. They have to have some medical opinion backing up the accusation. And so slowly it is improving. Our situation is improving. And because we were at one point thought that our children, what will be the future of our medical generation, like when they're harassed in all the ways, every day some new act and law is coming, and it becomes so difficult for people to practice peacefully and with free will. And on the other hand, there was also a problem of, that problem is still there, that physically we are getting attacked and abused and all those things are still happening, but to a lesser extent, we are trying our best to make it a IPC Act so that it becomes a Indian Penal Code Act. So people will think 10 times before doing such things. So the basic is that we must make more members, because that number strength is most important. We are a good strength, but still we have a lot of work to do as far as membership is concerned. So I request all of you, and please implore all of you to make more members. Always keep in mind that if you meet any colleague, ask him whether he's a member of the Indian Medical Association or not. And this goes especially for the consultants, because they are members of their own field, and then they don't become members of Indian Medical Association. So I always request that all those people who come to IMA, they should be members of IMA, or they should become members of IMA, because that is the only way we can, go forward, progress forward, as far as all the welfare of the medical fraternity is concerned. It's very important, because the future we have to be very strong. So I think with this, I pass on the mic to Dr. Usha or Dr. Anil Awad, whoever. Thank you very much for listening to me. Thank you.
Thank you, Dr. Jitesh Mehta. Now we'll start the program. The first speaker is Dr. Puneet Jain. He is a consulting hemato-oncologist. And I request IMA CGP member Dr. Sarita Devi to introduce the speaker.
Yeah, good morning all. Dr. Puneet Jain is a consultant hematologist and hemato-oncologist and bone marrow transplant physician at Apollo Cancer Center, Navi Mumbai. He has done his MD in General Medicine from JJM Medical College and his DM in Clinical Hematology from Christian Medical College, Vellore. He then did his fellowship in leukemia and hematological malignancies from MD Anderson Cancer Center, Houston, USA. His areas of interest include bleeding disorders like hemophilias, von Willebrand disease, thrombophilia, malignancies like leukemias, multiple myelomas, and lymphomas, antilogous and allergenic bone marrow transplants. He is a recipient of ASH Abstract Achievement Award at annual American Society of Hematology Conference in 2015. He has several publications in national and international journals and presented numerous papers in national and international conferences. Today, he will speak on hematological manifestations in COVID-19 and rational use of anticoagulants. Sir, welcome you. Dr. Puneet Jain, please.
Sir, what is the ASH award?
It is just we presented our data on acute lymphoblastic leukemia. That was way back in 2015. So we present in I have a paper on adult acute lymphoblastic leukemia, some 507 patients. In fact, one of the largest studies in the country on ALL, acute lymphoblastic leukemia. So, it was a study from Vellore. So we had presented it as an abstract. So it was just recognized. So a lot of students, to encourage the youngsters, these ASH is American Society of Hematology. They encourage. So a lot of people get those awards, but it was a good feeling for a youngster coming from,
of course, definitely.
So anyway, so I'll start my program. I might talk. My time is short. Can everybody see my slide?
Yes.
Yes, sir.
So good morning, dear friends. I hope everybody is safe, and it's a happy occasion today. So I'll try and keep my talk in the allotted time as much as possible, and then if we get time, we can have some discussions. The raging topic now is COVID-19, and I thought I will talk on hematological manifestations of COVID-19 and the rationale for use of anticoagulants in OPD, outpatient, inpatient, with some evidence and data that is presented. So this presentation is mainly meant for teaching purpose and has been compiled from obviously known textbooks and authors who have duly been acknowledged. So now we know that the initial evidence for coronavirus was in 8th December 2019. Okay, when several cases of an acute respiratory illness was caused at that time from an unknown pathogen reported in Wuhan, the Chinese city. So very rapidly, this infection was identified and the pathogen was isolated on 7th of January as a novel virus, and it was called as 2019 novel coronavirus or the SARS-CoV-2. Now, this is a single-stranded RNA virus that is very infectious and easily transmittable from human to human. Now we know that it is mainly the respiratory viruses. It is not through touch and fomites. It is mainly through the respiratory secretions. So initially the bats were identified as a main reservoir in China, and there is evidence that in the SARS-related coronavirus in bats can use the ACE2 receptor, which is the main receptor for cellular entry into the body. Similarly, in humans, a lot of these cells have these ACE receptors, including the pneumocytes in the lungs, the endothelium of the blood vessels, and so on, which are a source of entry of these viruses into the body. So if you look at the clinical spectrum, it ranges from asymptomatic to severe pneumonia or an ARDS resulting in respiratory failure and death, which is the most distressing symptom of COVID-19. If you look at all the frequent clinical imaging and the paraclinical findings, predominantly, if you see, it is the cough that is the presenting symptom in all non-severe and severe patients. And then, of course, fever, which is less common. And then severe fatigue, like any other viral, and so on. What is more common is cough, fever, extreme fatigue, and tiredness. And then there are a lot of other viral-related symptoms. Now, we will discuss about the laboratory findings in the next few slides. But if you look at the whole spectrum, lungs again have ACE receptor, so it causes alveolar injury, diffuse pulmonary intravascular coagulopathy, atypical ARDS. It can affect the kidneys because the ACE2 receptor are there in the podocytes and the messenger cells, so it can lead to kidney injury. It can affect the CNS. There are a lot of cases that are getting published from the neurological manifestations. It could be from Bell's palsy to stroke. So there is direct CNS invasion because of the ACE receptor. There is loss of smell. Why? Because there is ACE receptor in the host olfactory and gustatory pathways which are affected. So often loss of smell, that is anosmia, or a loss of taste is what is getting directly involved. Cardiovascular, again, heart can cause all these symptoms. So GI, the second wave came with a lot of patients presenting with diarrhea. So diarrhea, because there are ACE receptors on the ACE enterocytes in the ileum and the colon. It can cause skin manifestations, endocrine manifestations, and then the focus now is on hematological manifestations. Lymphopenia that happens is predominantly because the ACE2 inhibit receptors are there on the lymphocytes. So it can cause apoptosis of those lymphocytes and lymphopenia. And that is the reason when there is severe lymphopenia, it is a sign of an indicator of a severity of the COVID infection in your body. And then there is, of course, the endothelium or the blood vessels getting affected, and then they land up with endothelial dysfunction, and it precipitates a hypercoagulative pathway and causing clots and thrombosis. Now, there are several risk factors which are coming, and these markers keep changing, keep coming. But the common alarming factors are a higher age group. A SOFA score is basically a severity score for assessing the organ function, a very high D dimer, low platelets, and then, of course, your other vital parameters like the respiratory rate and heart rate. But your higher the age, as you can see, higher D dimer are two important markers which are kind of a poor prognostic markers. So what are the key hematological abnormalities? Lymphopenia, neutrophilia, mild thrombocytopenia. Thrombocytopenia is not that common. Monocytopenia, high LDH, very high ferritin, COVID-19 associated coagulopathy. You may have very high D dimers, prolonged PT, aperitif, and fibrinogen. Now, what about lymphopenia? These are the most commonly reported blood abnormalities. Occurs in almost 35 to almost 83. The range is huge. 83% of the patients. More commonly, they come with a very low ALC, absolute lymphocyte count in severe cases of COVID-19. There were two studies which were reported. One was from Singapore and one was from Wuhan, where they found that the median nadir of the ALC was significantly lower in patients requiring admission to ICU, as well as neutrophilia. So a very low lymphocyte count was an important marker of severity of the COVID infection. In addition to that, what COVID also does, it affects the T cell more commonly. So it damages the T cell ratio. So if you see that in addition to both a significant risk reduction in CD4 and CD8 T lymphocyte subsets, the severe cases of COVID had a much lower CD8 lymphocytes, and then it subsequently increased positive correlated with improved clinical outcomes. If you look at low platelets, usually it is a lower, less common manifestation, and it is usually mild. Very severe thrombocytopenia isn't that common, unlike a dengue or other viral infections. Even in anemia, it can lead to something what we call as anemia of chronic disease over a period of time. If the patient has had a prolonged admission in the hospitalization, and the patients develop anemia of chronic disease. But there have been some cases of autoimmune hemolysis anemia. I myself have had one or two patients at least with severe Coombs positive hemolytic anemia after recovering from COVID-19. Now, we evaluated that patient and we did not find any other cause, and hence the correlation to a COVID-19 infection causing an autoimmune hemolytic anemia. It recovered completely with a short course of steroids. But anemia, two presentations. One is an autoimmune hemolytic anemia, and then chronic patients, they develop anemia of chronic disease. If you look at the white blood cell, it causes a lot of dysplasia. Dysplasia in the sense, like if you see a neutrophil, normally it has 5 lobes in every neutrophil. So what is happening here? If you see, these are neutrophil granulocytes with only 2 lobes, unsegmented pseudopelgaroid. These are all anomalies. There is a lot of dysplasia in the white blood cells. If you can see this diagram, there is a lot of vacuolation. If you see this, there is too much of granulation. If you see this slide, this is again excessive granulation. If you see this, these are platelets which are vacuolated. So these vacuoles, if you see, they're not very common. So you tend to see a lot of granularity, lot of dysplasia. The lobes become dysfunctional, so it can cause dysplastic changes in the neutrophils also. On the right, what are you seeing? This is a bone marrow slide. Basically, what you're seeing, these cotton-like cells, these are called macrophages. So this patient actually had something what we call as hemophagocytosis, means one excessive cytokine storm causing macrophage to eat up all those cells. If you can see this right corner diagram, this is the cotton, blue fluffy cotton shaped macrophage, which has cells inside, it's eating up the lymphocytes, eating up the neutrophils. This is called as hemophagocytosis. So these manifestations are rare, but it can be seen. Commonest, of course, is mainly the lymphopenia, which is there in COVID-19. Again, these are all the different types of blood smear, again, affecting different types of cells. This is the eosinophils. These are giant platelets. These are the large lymphocytes. Basically, COVID-19 can affect all the cell lines of your blood. Now, importantly, an update on COVID-19 associated coagulopathy. Now, this is an important statement for you to know, that the author, Marcus, had said that we are so much accustomed to attribute to a single cause always, but that is a product of several, and the majority of our controversies come from that. What he meant that was many times there are too many causes that are leading to one final diagnosis, and it is not that there is just only one cause. Here, COVID is the common etiology, but then the coagulopathy that happens in COVID occurs due to a lot of reasons. It could be because of hypercoagulability secondary to the endothelial damage. It could be because of the liver dysfunction. It could be because of several other causes that can cause the coagulopathy. As you can see this, On the left side, this is an ACE receptor. These are alveolar epithelial cells. This is the COVID-19 virus. It is entering through the ACE receptor. It is replicating. It is being released. There is viral shedding. It is affecting the endothelial cells. Then, because of the endothelial cell damage and acute inflammation, a lot of acute phase reactants are released. Fibrinogen, von Willebrand factor, they are getting activated. Platelets are getting activated. And all this leads to a clot or a thrombin. This releases D-dimer because every thrombin that is created, it will be broken down and then D-dimer is released. So it's a constant state of cycling that is happening in the body. And of course, it precipitates at several levels. Platelets are getting activated. There are acute phase reactants, endothelial dysfunction, and a lot of cytokine storm that leads to coagulopathy. This is again the same thing that I'm trying to show, but importantly, we have seen, I'm sure a lot of you would have seen clots that happens in patients with COVID-19. So coagulopathy does not, here there is a dysfunctional coagulopathy. So there is a lot of thrombosis also that is predominantly happening. These are again the same diagrams which are trying to show the same cartoons, how they affect the enter through the pneumocystes and replicate, and how they damage the endothelial cells. And then there is platelet activation. There is all the secondary hemostatic factors that come in, and then more inflammation and subsequent thrombosis. So if you look at the possible mechanisms, it is platelet activation, it is increased thrombin generation, it is direct viral to platelet interaction. Platelet clearance means platelets going thrombocytopenia due to increased endothelial damage. Autoantibodies, we have had patients with autoimmune thrombocytopenia, splenic sequestration, and suppression in the marrow. So these are all the laboratory abnormalities that you would see with COVID-19, and even those with worse COVID-19, high LDH, high ALT, high cardiac troponin, high kidney functions. These are all markers of acute phase reactants, Procal, ESR, CRP, factor VIII, von Willebrand factor. Coagulative changes, predominantly high D-dimer, prolonged PT. Sometimes you get shortened or prolonged APDT, low platelets. These are antithrombins, which are physiological anticoagulants that can reduce, and of course, low lymphocyte count. Now, D-dimer in COVID-19, it has kind of become one of the most important tests that people are using. But it's very important to understand that D-dimer is also an acute phase reactant, and you have to use it in conjunction with other available markers. Just a high single D-dimer sometimes may not be the right indicator to or an alarm bell. You have to clinically correlate these values in patients to be able to give the right kind of anticoagulants. Now, what is D-dimer? As you can see, whenever there is a clot that is formed, the end clot, that is a thrombin, it gets stabilized with a factor called as factor 13. As you can see, so once factor 13 comes in, it cross-links all the clot. And when that is broken down, D-dimer is released. So D-dimer is a specific fibrinogen degradation product. So once the clot is formed, the fibrin mesh is formed, factor 13 is stabilizing the clot. That clot, when broken down, which is continuously happening in our body, then D-dimer is released. So D-dimer is specific. What does D-dimer signify? It signifies more of fibrinolysis, means a clot was formed and it was broken down. That means the body is undergoing that cycle in that phase where D-dimer is high, means you had a clot. It's a sign of a clot in a body, but it has its value and significance attached to a lot of other covariables. Now, you have to understand that it is a sensitive marker to rule out venous thromboembolism. Now, if I have a patient who has a D-dimer, normal D-dimer, then it has something what we call as in statistics a negative predictive value. Means that negative D-dimer or a normal D-dimer is more assuring for me that probably the patient does not have any clots in the body, rather than a positive predictive value that of D-dimer is high, okay, patient has a clot. The point I'm trying to make is it is a sensitive test. It is not entirely specific. So D-dimer can be seen as a acute phase reactant. It can rise in inflammation, malignancies, traumas, heart disease, severe sepsis, or pregnancy. So there were a lot of studies which were retrospective predominantly initially, which looked at isolated D-dimer and of course the scoring system, something what I use the word SOFA score, and in trying to look at other organs. So some studies showed that if the D-dimer is more than 4 or 6 times the normal, then the risk of worsening of or the severity of the COVID is much, much higher. Now, there are several ways you can measure D-dimer, depend on what lab you do. Some of the labs use different instruments. So you may find a value of a D-dimer more than or 1 microgram per ml. Then the instrument that they are using is the diagnostic Stago. So 1 is a high value. Sometimes they use the different D-dimer like a Siemens. Value is then 1000, 1500 is the value. So what instruments and what valuations is being used is important to be able to interpret the D-dimer. This is just the type of presentations in trying to differentiate DIC from COVID-19. As you can see, it is not very easy to classically differentiate DIC from COVID-19 because it can affect every protein that is involved in the coagulation pathway. This is again the same thing that I'm trying to say, that a lot of studies were published, some with a D-dimer. So if you have a patient with COVID-19, excessive lymphopenia, he is little breathless, and then the D-dimer is more than 4 times or 6 times in conjunction with the other values, then yes, you are looking at a prolonged stay for a patient, maybe needing an ICU. The patient might be needing a lot of anticoagulation, and we will discuss about that in the next few slides. Now, venous and arterial thrombosis, how incidence and management. What is the incidence of clot? How common is a arterial or a arterial vessel clot in COVID-19, and how common is a venous clot? If you can see, the cumulative incidence of the venous is somewhere between 10 to 15% in what the major studies are there, and an arterial clot is around less than 4%. So these are all the different studies that have shown the cases. Some show 25%, some show 10%, 46%. But these were mainly those patients who were very sick and who were in ICU. So if you're in the ICU, you have a higher chance of clots that were diagnosed. So this was more of patients who were admitted and hospitalized and who were sick, and when they found a higher value of venous thromboembolism. But if you look at the whole spectrum of COVID-19, you will realize that the incidence of COVID-19 is probably 15%. COVID-19 related venous thrombosis is 15%, and arterial events is around 4% or less. This was actually meta-analysis, means 64,000 patients data was systematically analyzed. So venous thrombosis around 15%, arterial clots is probably less than 4%. But yes, I'm sorry, what matters a lot is the pre-existing comorbidities, and that also decides the outcome. Now, sometimes we have seen strokes also, but yes, the incidence is low, but it is there. So how do you approach these patients with D-dimer? The D-dimer, if the D-dimer, you will do a D-dimer in diagnosis, platelet is low, the lymphocyte count is low. Then if the D-dimer is very high, prothrombin time is prolonged, platelet is less than 1 lakh, then yes, the patient needs admission and monitoring, and then sometimes anticoagulation is also needed in admitted patients. So this is what Mayo Clinic uses. If you have a D-dimer level less than 3, then prophylactic and enoxaparin or Clexane can be used. If the D-dimer is very high, then we can use, so these are the 3 categories, category 1, category 2, and category 3. Means if the D-dimer is less than 3, more than 3, and this is full thrombosis. So in category 1, that is low D-dimer, we use a low dose enoxaparin when it's 40 milligram once in 24 hours. If the D-dimer is more than 3, then we use intermediate dose, that is 40 milligrams every 12 hours. And if in a full clot, a patient who has developed a full clot, we use a full dose of anticoagulation. So you have to obviously look at all the kidney functions when you're using low molecular weight heparin. I tend to use fondoperinox or sometimes dalteparin in patients with renal dysfunction, but we stick to injections while the patient is admitted, and then when he's getting discharged, we can switch to oral tablets. You have to understand that unless there is a venous thrombosis, clot, or evidence of a full-fledged clot, there is no point in giving full dose of Clexane. It has to be either low dose or intermediate dose. So therapeutic anticoagulation in absence of any existing clot has no benefit over prophylactic anticoagulation. Duration, normally, if there is a classic venous thromboembolism, then we use it for minimum 3 months or even up to 6 months. But those who have had pulmonary embolisms, then I tend to use it in at least 9 months or so, and then take a call based on the comorbidities and the intensity of the clot at the diagnosis. What is a follow-up scan? What is a D-dimer? And then it's a clinical approach. Yeah. So this is the ASH, the American Society of Hematology guidelines. Again, that's the same thing that I was trying to say, that they use prophylactic intensity over intermediate intensity or therapeutic intensity anticoagulation who do not have a suspected or a confirmed venous thrombosis, and who do not have a confirmed venous thrombosis, you tend to use the intermediate, or I mean the low dose Clexane is what is usually preferred for admitted patients. Now these are all the types of drugs that have been used in prophylactic, like we can tend to use apixaban, we can use enoxaparin, fondoperinox, unfractionated heparin, rivaroxaban is a maintenance dose 10 milligram. These are the common 3 or 4 drugs that we tend to use. What about those patients who are discharged, who are stable, who do not have a clot? Then we use at least 6 weeks or 45 days post-discharge prophylaxis can be considered, in especially those patients whose D-dimer was greater than 2-fold at the time of diagnosis. Because then once they get discharged, there is a tendency of a patient coming back with clots. I think I'll skip these slides. Anticoagulation, they also found that if you use oral or enoxaparin, there hasn't been too much of a difference, but just for practical purposes, and we tend to use enoxaparin in the wards, but then that is an institutional based practice, then that could differ. Some people prefer using apixaban or rivaroxaban, but we tend to use more of low molecular weight heparin while the patient is admitted, and if he does not have too many comorbidities. This is an important slide. There was a lot of hue and cry over use of favipiravir as one antiviral drug. And in fact, I had even read one report that the market revenue of favipiravir is so high that, you know, it is really a very commonly used drug. But you have to understand that it has some drug-to-drug interactions. Now, if you see, enoxaparin has no interactions with favipiravir. Green is no interaction. If we see the red, rivaroxaban and the oral anticoagulants, we tend to avoid it with favipiravir. So this is an added reason why we tend to use enoxaparin more in patients with who are admitted. And you have to be careful when you use these drugs because there are a lot of drug interactions that we should be aware about. I think I'll close my talk and I'm happy to take questions.
Dr. Puneet,
Yeah.
how do you compare fondoperinox and enoxaparin? Because fondoperinox.
Yeah, so we can, we mean the both are and both are injectable anticoagulants. Low molecular weight heparin is much more widely used. Fondoperinox, sometimes we tend to use in patients with renal dysfunction. We tend to use in patients with sometimes who have developed a HIT or a heparin-induced thrombocytopenia. Then we use very rarely fondoperinox. But in general, 5 milligram or 7.5 milligram of fondoperinox is equivalent to our standard use of low molecular weight heparin. Maybe 1 milligram per kg. That's the comparison. And
Okay.
I mean, maybe a nephrologist, if we have anybody on board today, may be able to answer those questions even better. But we tend to use fondoperinox or dalteparin in patients with renal dysfunction.
Okay, more in real.
Dr. Puneet, there's one question in the chat box.
Yeah, I'm not able to. 1 minute. Was my voice very clear? Because
Yeah.
Okay. Yeah.
Yes.
Yeah. Go ahead. Go ahead.
Yeah, there's one question in the chat box. For how long should blood thinners be used in case of D-dimer elevation post-COVID in patients with diabetes and hypertension, but otherwise stable and mobile patients?
Yes. So this is a good question. And as a hematologist, I would want at least 6 weeks for anticoagulation. But it's good to always take an opinion from a cardiology team who is also handling the blood pressure or the intensivist. But in general, we tend to use it for 6 weeks with a high D-dimer and no major other major comorbidities. That's what we use. But then, these guidelines, they vary. It is people tend to use it for 6 weeks, but then sometimes some people may use it for less. As I showed you some evidence also on it.
Sir, when to switch off injectable and switch on oral anticoagulants?
See, as soon as what we tend to use is injectable as much as possible because of the shorter half-life. Even rivaroxaban probably has a half-life of 12 hours, but it's just that reversibility is an issue. So once the patient is discharged, we put on oral anticoagulants. What we tend to do is the next dose of especially when the patient is on therapeutic anticoagulation, 2 hours before the next dose of the injectable, we start the NOACs. And of course, the patient should be not having too many other comorbidities like the kidney functions and all that. But when we discharge, we put on oral. And as I showed some interaction with favipiravir and all.
Yeah.
Any question more?
Yeah. Is there a test for post-COVID patients to monitor and scare them because they completely ignore COVID protocols simply because they have been vaccinated?
Maybe you take a stick, keep a stick with you. Because that's a common problem. I do not have a solution for that.
Yes. Okay. Sir, there is a last question. What will be your take-home message?
I think we are still learning. There is a huge amount of information that we still are probably not aware about. We need to keep talking like this, learn from each other, and stay. COVID-19 can cause a lot of problems. We should use values in interpretation of the clinical findings. What I've noticed is a lot of people, commonest question that I've had from my talks is people were not aware that favipiravir has got some drug interactions. And this was also, I also realized it when I was making this talk long back when I first made this talk.
Yeah.
So I think we need to keep talking, reading. There is a lot we do not know about. Interpret the values. Just do not. I'm seeing patients with dengue in whom the D-dimer is being done. So D-dimer is not like the only value that is important. You have to correlate with your other laboratory findings and then discuss and do best for the patient.
Thank you very much, Dr. Puneet, for your kind words. Over to Dr. Usha.
Yeah. Thank you, Dr. Puneet Jain, for giving an excellent information about the hematological manifestation of COVID and rational use of anticoagulant. Now we'll go to the next speaker, Dr. Richa Bansal. She is a consulting gynec oncosurgeon, laparoscopic and robotic surgeon. Now I request IMA CGP member Dr. Kashyap Dakshini to introduce the speaker.
Good morning, friends.
Over to Kashyap.
Good morning, friends. Dr. Richa Bansal is a consultant gynecological oncosurgeon, laparoscopic and robotic surgeon at Apollo Cancer Centers, Navi Mumbai. She completed her MBBS from Padma Shri Dr. D.Y. Patil Medical College, Nerul, Navi Mumbai, and her MS Obstetrics and Gynecology from Lokmanya Tilak Medical College and Hospital. Dr. Richa Bansal then pursued her MCH Gynac Oncology from the prestigious Tata Memorial Hospital, Mumbai, where she worked for over 6 years in the Department of Gynac Oncology. Her surgical expertise is performing all the supra-major gynac oncological procedures, including open, laparoscopic, keyhole, and robotic surgeries for gynecological cancers, including cancer of ovary, uterus, cervix, vagina, and vulva. In addition to performing radical cancer surgeries, prevention of cancer and spreading of cancer awareness are also her passion, and she has been an invited speaker for cancer awareness in women on several national and international platforms. She has presented scientific papers in several national and international conferences and has also contributed to book chapters in the field of gynecological cancers. She is committed to deliver the best care and treatment to women with gynecological cancers, and also to have a dedicated HIPEC and robotic program at Apollo Hospital, Navi Mumbai. Today, she will speak on the overview of gynac oncology. Welcome, Dr. Richa Bansal.
Thank you so much. At the outset, I would like to sincerely thank IMA Mumbai, Dr. Jitesh Mehta sir, and all the dignitaries present here, and of course our Apollo Hospital for giving me this wonderful opportunity. And it's my really pleasure and privilege to be talking to you all today. So I would be giving you an overview in gynecological cancers. So thank you for the kind introduction. Now, gynecological cancers are indeed an important public health problem in India. The incidence of majority of the gynac cancers like cancer, cervix, ovary, uterus, the incidence is rising. And of late, we are also observing that the cancer is occurring in more younger age groups as compared to the more conventional age groups. Like uterine cancer conventionally is known to occur after the age of 60 years in postmenopausal women. But of late, we are seeing a lot of young women with the uterine cancer and ovarian cancer and so on. And this is the reason that we all should be aware of these symptoms so that we can better care for our patients. So according to the Globocan 2018 estimates, there have been around 97,000 new cases of cervical cancer, 14,000 new cases of endometrial, and 36,000 new cases of ovarian cancer in India. Now, apart from the actual incidence, what is even more concerning for me as somebody who is dealing with the women cancers is that the cancers in our women are being diagnosed in more locally advanced or in metastatic stages. So this is what is more concerning. We all know that, discussing period problems or women private problems in, society is a big taboo, not just in the rural or uneducated societies, but also in most Western and, well-to-do societies. And this could be the main reason that women, they do not share their problems so easily, even with their own family members. And there's a definite delay in they're presenting to the clinician. So as we all can see, this all data is from our own country. And as we all can see, for example, cancer of the cervix, the frequency of cancer cervix that gets diagnosed in stage 1 when the cancer is still confined to the uterus and is absolutely curable with radical surgery. The incidence is just 11%, whereas the incidence of more advanced stages is more and more. And we can see more than 50% of cancers are being diagnosed in stage 3, where it has already caused a lot of complications in the body and including renal failure. Cancer of the endometrium is an exception, usually gets diagnosed in stage 1. So that is one good thing, but we still need to treat this cancer endometrium well, because majority of the symptoms of gynec cancers are like, any other symptoms which could be suggestive of some benign problem, like just heavy bleeding. So many a times, doing the proper investigations, evaluation gets missed, and they just get treated in a conservative way. Similarly, if you will see for cancer of the ovary, 60% of cancer ovary gets diagnosed in stage 3, and similarly is the case for cancer of the vulva and vagina. So this is where we need to work upon. We should be able to diagnose more and more cancers in earlier stage, when the cancer is still curable, with simple treatment protocols, and with less complications for the patient. Now, coming to the cancer of the ovary. Now, whenever a lady presents to me with an ovarian cyst or adnexal mass, I think a lady, ovarian cyst diagnosis is one of the most common incidental diagnosis on a routine ultrasound examination of the abdomen. So whenever a lady presents to me with an adnexal mass or an ovarian cyst, how do I know that what is the risk of malignancy in this ovarian cyst? So it's very important for me to have an idea of the risk of malignancy in this ovarian mass, because my entire further evaluation and treatment will depend on my perceived risk of malignancy. So what are the clinical parameters that we can use? So age group. Conventionally, we have seen that ovarian cancer, the typical ovarian cancer, occurs more commonly in older women after menopause. But like I said, of late, we have been seeing a lot of even young women in their 30s and 40s being diagnosed with ovarian cancer. Clinical history is very important, especially recent onset symptoms, and especially when the symptoms have been worsening over the last few days without any relief from the conservative medications. Then this should be considered as alarming, and one should actually investigate. Actual symptoms of ovarian cancer are actually very non-specific and vague, like just vague abdominal pain or constipation, or just feeling full after eating, or early satiety. So actually these symptoms can be mistaken for a variety of other not so concerning problems, and that is why the presentation to the clinician and actual investigation is actually quite delayed. Again, coming to family history is very important. Ovarian cancer, 25% of all ovarian cancers can be hereditary. So it is very important for a clinician to ask a family history. And if there is family history of especially breast or ovarian cancer in close family relatives, then we should alert ourselves that probably this lady, the suspicion of having a malignancy in this lady with the ovarian mass would be higher. Clinical examination, again, if there is a ascites, or if there is a really hard fixed pelvic mass, especially bilateral ovarian masses, and especially if I can also feel some other pouch of Douglas nodules, supraclavicular lymph nodes, inguinal lymph nodes. So all these parameters raise my suspicion of dealing with a malignancy. So clinical examination is should be done very carefully. Then, of course, I will discuss in my further slides about tumor markers and radiological imaging. And actually, we use one or more of these indices to predict our risk of malignancy in ovarian masses. So CA125, we all know that CA125 is a standard tumor marker test that we do for a lady who's presenting with an ovarian mass to support or rule out our diagnosis of ovarian cancer. There are a few other markers like CEA and CA19.9. CEA and CA19.9 are basically lower GI tract and upper GI tract markers. Many a times, GI malignancy can first present with an ovarian mass if the cancer is already metastasized to the ovaries. And hence, as a routine protocol, and especially if the lady also has significant GI problems like constipation, loose motions, excessive vomiting, or history of black stools, then definitely we should do these two markers as well. Especially important for all of us to note here is for a young girl or young woman, especially in her teenage or in her 20s, who presents with an ovarian mass, complex ovarian mass, we could be dealing with malignant germ cell tumor of the ovary, which is more common in the younger girls. And in these cases, so whenever a young girl is presenting with a complex ovarian mass with complaints of abdominal pain, we should never miss out on doing the germ cell tumor markers, which are AFP, beta HCG, and LDH. Because these tumors are really very fast growing, but the prognosis is actually really very good if these tumors have been treated appropriately with surgery and chemotherapy. So diagnosis of a malignant germ cell tumor of the ovary should always be in mind whenever we are dealing with a young girl who's presenting with a complex mass. Typically, these masses tend to be larger, more than 10 centimeter size, and solid cystic on imaging. So imaging, whenever we are suspecting any problem related to ovary, the first go-to test is an ultrasound examination, which gives us a clear characteristic of an adnexal mass. The MRI I do less frequently for a lady with ovarian mass, only when she's young, and when I really want to see how complex is this ovarian mass, whether there are thick walls, thick septations, solid areas. When I want to triage between conservative management versus surgery in especially young girls. And CT scan is more commonly done investigation, especially in older lady who is presenting with a complex ovarian mass. And basically it is to look for ascites and any extra ovarian spread of the disease in the form of retroperitoneal lymph nodes, omental disease, peritoneal disease, and so on. And of course, we also advise upper GI and lower GI scopies. Like I said, whenever we have significant GI tract symptoms or when these tumor markers are elevated. So because ovarian cancer is the most lethal gynecological cancer, it is always advisable to err on the side of caution. Even if we are doing an extra investigation or extra, blood test, I think it is still worth doing for the fear of missing an ovarian cancer in a lady, because actually the symptoms being so vague and so non-specific. I think we should be more cautious when we are dealing with these symptoms. So whenever there is a suspicion from the tests that ovarian cancer might be present, the patient should seek referral to an oncologist for cytoreductive surgery and further treatment. The gold standard of treatment for cancer ovary is cytoreductive surgery followed by chemotherapy. And the goal of a cytoreductive surgery always in every case should be to remove all the tumor from the abdomen. And only then, only if the surgeon is able to remove all the tumor from the abdomen, it is possible to confer the survival advantage for the patient. And for this reason, research, there are many scientific studies which have shown that women treated with the oncosurgeons have better survival than those treated by general gynecologists and general surgeons. And these scientific studies have led to many international guidelines, many international society guidelines like American College of Obstetrics and Gynecology, SGO, which recommend referral to a oncosurgeon if there is elevated blood level of CA-125, presence of fluid in the abdomen, if there is an ovarian mass, or if there is evidence of abdominal and distant metastasis. So these are the few pictures of ovarian mass. The first picture here is that of an early stage ovarian cancer. We can see there are bilateral large ovarian masses with capsule intact. There is no disease on the ovarian surface, and whatever part of the opened abdomen is seen, it looks quite clean. The bowel loops look quite clean. So it's probably an early stage ovarian cancer. And this is the cut section of the ovarian cyst where there are multiple solid areas which can be seen. These are the solid tumor areas. Now, the lower row is that of advanced ovarian cancer. We can see a huge omental cake. We can see liver surface deposits. We can see miliary deposits on the paracolic gutters. So these are our actual intraoperative photographs. This picture showing a huge ovarian mass. When we removed this mass and sent for a frozen section examination, it confirmed endometrioid adenocarcinoma of the ovary, which required a full surgical staging for this lady, including a comprehensive retroperitoneal lymph node dissection. And these are the subdiaphragmatic deposits. We can see here there are deposits on the subdiaphragmatic peritoneum which need to be removed, and these are all perisplenic deposits. So coming to the management of recurrent CA ovary, you selected ovarian cancer when initially treated. 80% of the patients will respond very well to the initial surgery and chemotherapy, but equally true is that 50% of the patients will relapse in the subsequent 2 or 3 years, and a few selected cases of ovarian cancer relapse might be suitable for secondary cytoreductions and tertiary cytoreductions, repeat surgery. And especially treatment of these recurrent ovarian cancers should be in a specialized center with a multidisciplinary team management. So this is a lady who had presented with a recurrent ovarian cancer with tumor mass in the bladder. So this is the cystoscopy picture of the ovarian cancer in the bladder, and this is the intraoperative picture. Here is cystotomy showing tumor involving the bladder and also involving the vesico-ureteric junction. So because this lady was young, 43-year-old, and there was limited disease confined to this part of the abdomen, and rest of the abdomen was quite clean. She was deemed suitable for secondary cytoreduction in our tumor board discussion, and hence she underwent the secondary cytoreductive surgery with partial cystectomy, left nephrectomy, and bladder reconstruction. A word about HIPEC. This HIPEC is hyperthermic intraperitoneal chemotherapy. It is actually delivery of heated chemotherapy in the abdominal cavity at the end of the cytoreductive surgery. So when we are actually doing the surgery for cancer ovary patient, once we have removed all the disease from the abdomen, what we administer is heated chemotherapy, diluted in the peritoneal fluid and at a temperature of 42 to 43 degrees Celsius. The scientific basis is that hyperthermia and chemotherapy will have a synergistic effect on the microscopic tumor cells remaining in the peritoneal cavity after we have removed all the gross disease. So it is actually these microscopic cells which remain behind in the abdomen after the surgery that cause future relapse. So based on this, we have devised, and there is a lot of scientific data which has shown improved survival for these women, which support this treatment with HIPEC. And it does have many advantages over standard chemotherapy. Mind you, the patient is going to receive the full course of IV chemotherapy. This is in addition to what we can do with surgery and chemotherapy. This is an additional treatment which of late has garnered a lot of attention from the ovarian cancer surgeons from around the world, and this is the standard treatment used in many parts of the world. So what are the advantages? It is a single treatment done in the operating room instead of multiple treatments over several weeks. Because 90% of the drug stays within abdominal cavity, the efficacy of chemotherapy is highest because we are delivering the chemotherapy right at the area where it is most needed. And also the systemic side effects on the rest of the body are reduced because very, very less quantity of this drug is actually entering the systemic circulation. And most of this drug is remaining in the abdominal cavity. And hence it allows for more intense dose of chemotherapy. So we are doing HIPEC routinely at Apollo Cancer Center for ovarian cancer patients and for GI cancers in suitable cases. Mind you, the case selection criteria are very strict, and we are, sorry, following those. Now coming to ovarian cancer in young girls, like I mentioned, malignant germ cell tumors of the ovary are the most common cause of malignancy in young women presenting with an ovarian cyst or ovarian mass. Peak incidence is in the late teens or early 20s, and they typically present as large unilateral abdominopelvic masses in young girls. The main symptom is normally abdominal pain. Sometimes there can be menstrual irregularities. And tumor markers which are specific are LDH, AFP, and beta HCG. So treatment is with surgery. They just need removal of that adnexal mass with omentectomy, followed by adjuvant chemotherapy. Fertility sparing surgery, meaning we can preserve the opposite ovary, opposite normal ovary and uterus. And after that, the patient receives chemotherapy. And these are potentially curable if they're treated appropriately. What do I mean by appropriate treatment is that laparoscopic surgery in untrained hands leading to rupture and dissemination of the disease should be avoided, as we have seen florid recurrences in the peritoneum after these, and chemotherapy should always be advised. So, we see many a times these young girls present to, local doctors, and because the tumor masses are so horribly looking, and they are actually, the tumor markers can be very high. So they undergo complete removal of the mass with uterus and ovary, and, the girl is rendered sterile for the rest of the life. Actually, these girls, if most suitable for fertility sparing surgery, and after completion of surgery and chemotherapy, the return of menstrual function and reproductive potential is seen in almost all the young girls. So these are the malignant germ cell tumors which we have dealt with. These are generally in 11 to 12 years of age, and we can see how vascular and dangerous looking these masses are. But they just need removal of this mass, and the opposite ovary and uterus should always be preserved. Now coming to the cancer of the uterus. Now, like I had mentioned, cancer of the uterus or womb is rising in our country, and this is because of rising incidence of obesity, diabetes, PCOS. All of us have heard about this, polycystic ovarian syndrome. And the incidence of, again, the PCOS is rising. So there is a very complex hormonal milieu which is rising because of obesity and PCOS, and which is causing excess of estrogen in the uterine lining, and which is leading to increased risk of uterine cancer in these young women. Also, women in their 20s, 30s are, we are seeing these women getting that. Again, another reason is infertility, delaying childbirth. Many of us, because of our career choices, we want to delay the first childbirth, probably even be beyond 35 years. And, this is what has also contributed to rise in the cancer in uterus incidence. Now, of late, having less number of children, and also familial uterine cancer is rarer as compared to ovarian, but can happen. It's seen in about 5 to 7% of all uterine cancers. But especially when uterine cancer is happening in a young woman, we will have a higher suspicion of her cancer being familial. So I urge that whenever a young lady presents with abnormal heavy period bleeding, the first thing that we think is, the suspicion of uterine cancer in young women will always be lower, and that is understandable. Now, we may not advise a biopsy for all of them, but we should be more cautious when especially the symptoms have been very severe, when she's been having persistent bleeding for at least 2-3 years. Recently I treated a 33-year-old lady with endometrial cancer who was having this heavy menstrual bleeding since 2018. She was advised hormonal treatment to decrease her blood flow and many other medications without actually having a biopsy done. So young women, especially who have history of any of these, obesity, PCOS, infertility, definitely our suspicion should be higher and endometrial biopsy should be advised. Now, treatment for cancer uterus is surgical staging with radical hysterectomy, removal of both ovaries, fallopian tubes, and a complete retroperitoneal lymph node dissection. And a lot of scientific data, randomized controlled trials all around the world have proven that robotic surgery is equally safe as compared to open. Oncologically, the survival is not compromised. And of course, there are several advantages of laparoscopy over open and laparoscopic. So advantages are decreased blood loss, length of hospital stay is less, early mobilization, decreased operating room time, decreased chances of conversion to laparotomy, especially in very obese women, where, of course, open and even laparoscopy surgery could be slightly difficult. And especially also for women with advanced stage and multiple comorbidities, we will always choose a minimal access route. And with robotic surgery, we can also do sentinel lymph node mapping with reduced long-term complications of lymphadenectomy. So this is the sentinel lymph node, which we are routinely doing for cases of endometrial cancer, where we map the lymph nodes and we remove the we remove only those lymph nodes which are getting highlighted with the dye. And this has shown to reduce the long-term complications of systematic lymphadenectomy like lymphedema and many other problems. Now, coming to cancer of the cervix. Now, cancer of the cervix was actually the most common cancer in women till last few years. Now it is at second number position after breast cancer. But still in many rural areas, many urban areas also, it still ranks highest. So what I want to say about cervical cancer is that it is really sad that we are suffering so much from a cancer which is completely preventable. Very, or I would say, very few of the cancers which affect us, which is completely preventable. And why do I say that cervical cancer is completely preventable is, first, we have this HPV vaccination. Now, I'll just give a quick background about the pathogenesis of cervical cancer. Now, cervical cancer occurs because of a human papilloma virus infection of the genital area. Whenever a couple start their sexual debut, normally we expect that in second and third decade, majority of the couples will develop this human papilloma virus infection. It's a sexually transmitted infection. It's the most common sexually transmitted infection. So 90% of the couples will develop this HPV infection in next 6 months. But equally important is that 90% of these couples will clear this HPV infection in next 6 months to 1 year. With the help of our inherent body immunity. So this infection happens, but it clears also in majority of the men and women. Only in 5 to 10% of women, this HPV virus will remain persistent in the genitalia. And the reasons could be multiple. Some inherent defect in the immunity, smoking, or repeated trauma, and there are many other things. So only in those few women in which this HPV infection is remaining persistent, this persistent HPV infection will drive the cervical cells to pre-malignant changes and then eventually to cancer changes. And this change, first HPV infection, then HPV infection remaining persistent, then it causing cervical precancer, normally which we call CIN, cervical intraepithelial neoplasia, and then it leading to invasive malignancy. These spectrum of changes actually happen over 10 to 15 years. So we actually have 10 to 15 years of opportunity to detect either this HPV infection or detect the cervical precancers so as to prevent the development of cervical cancers. So HPV vaccination is recommended for young adolescent girls. Ideal age is between 10 to 15 years. We have two brands available, Cervarix and Gardasil. Both are equally good, nothing to choose between the two. And safety and efficacy has been demonstrated in large studies all over the world. And in fact, majority of the Western world has been able to decrease their cancer of their incidence of cancer cervix with the help of this HPV vaccination, where this HPV vaccination has been incorporated in their national immunization programs. A lot of efforts are being done from experts, public health experts in India as well, and especially my teachers at Tata Memorial Hospital to get the Indian government moving about this and to incorporate this HPV vaccination in national immunization programs or in school-based programs where every girl who reaches 11 to 12 years is vaccinated in the school itself. So HPV vaccination is, it's 100% recommended, absolutely safe vaccine and 100% efficacy. Now, second step which we can take, or second tool that we have in our armamentarium to prevent cervical cancer is cervical screening with pap smear and HPV test. Every woman beyond 35 years of age, between 35 to 65 years of age, is recommended to undergo a pap smear and HPV test every 5 years. So it is not even to be done yearly or things like that. Every 5 years, just once in 5 years, we have to do this test. Hardly takes 5 to 10 minutes, not at all painful, can be done in with any gynac. And there are many laboratories which are available and which will report these results. Normally, the cost is between 3,000 to 4,000. The cost of vaccine is around 3,000. So every 35 to 65 years of age, every woman should be advised to undergo this screening test. So like I said, other reason why I say that cervix cancer is preventable is because it has long pre-invasive state. We have at least 10 years time in that. 3 tests can be done in these 10 years, to detect these pre-malignant changes in the cervix. And of course, if a pre-malignant change is detected, this pre-malignant change can be easily treated with simple measures. Mind you, it's not hysterectomy. We can do colposcopy, LEEP, and many things, and so as to cure this lady and prevent her from developing cervical cancer in future. So these are few biodiagrams that I'm showing for making you aware of this health impact of HPV vaccination followed by cervical cancer screening. So if we are advising only vaccination, then still we can reduce this cervical cancer incidence and mortality by 44%. But if we are combining the two, the impact that we can achieve is much higher. And these observations have been even endorsed by WHO. And recently in 2019, WHO has made a call for elimination of cervical cancer. The plan is to get by 2030 to get 90% of our girls fully vaccinated by 15 years of age. 70% of the women should be undergoing screening with this HPV test at least 35 and 45 years of age. These tests are this HPV test is so effective that if a woman today does HPV test and the test comes as negative, the risk of her developing cervical cancer in next 10 years is actually very low. So many population-based studies have shown that even if this test is done just at 35 and 45 years of age in her whole lifetime, it will still reduce her risk of dying from cervical cancer significantly. And all these things will lead to 30% reduction in cervical cancer. So I think I've already mentioned about this graph. The HPV infection happens in younger age, but majority of the women clear that this HPV infection. Only in few in which it is remaining persistent, it will lead to cervical cancer and cancer. And we do have a long window to detect these changes early and treat. Another thing which I want to highlight is that early cervical cancer normally does not have any symptoms. So it is only screening which will help us to diagnose this pre-cancer, and if already cancer is developed, to diagnose this cancer early. Once the symptoms develop, normally it is advanced stage, though we still get a lot of early stage cancers also when the women are able to notice even slight changes in their menstrual pattern. But to generalize the things, I always say that early cancer, and to motivate everybody to undergo the cervical cancer screening, I always say that just assume that early cancers will not give rise to significant symptoms. Once there are significant symptoms troubling the woman, and actually when she comes out and tells family members that I'm having these period problems, especially true for old age women, the cancer is already advanced. So what are these risk factors for developing these pre-invasive lesions of the lower genital tract? Why do only some women are not able to clear this HPV infection and are predisposed to develop this? It is the sexual history, especially early onset of sexual activity before 18 years of age, early age at first childbirth, less than 20 years of age, multiple lifetime male partners, also characteristics of partner if the partner is having some high risk sexual behavior, and also co-infection with other sexually transmitted infections. Tobacco, any form of tobacco, even that missionary chewing or any form of tobacco is dangerous, and of course HIV and immunosuppression. What are the symptoms? Any unusual vaginal discharge, especially if it is foul smelling, vaginal bleeding after having coitus. Now, this is very significant. They typically complain of spotting or bleeding after having coitus. Any unusual bleeding or spotting in between normal periods. The 2 periods will be normal, but in between there will be some spotting. And postmenopausal bleeding. Any form of postmenopausal bleeding in our country, if a woman is having postmenopausal bleeding, then the frequency of diagnosis of either cervical cancer or uterine cancer is about 30 to 40%, and it is very significant. So any postmenopausal spotting or bleeding should not be ignored, and these old women should be thoroughly investigated. And like I said, early cervical cancer may not produce any symptoms and can be diagnosed only if the woman is undergoing routine screening. Now, in short, treatment of CA cervix when stage 1 is potentially curable with radical hysterectomy and pelvic lymph node dissection. And in more advanced stages, the patient will require radiation therapy and chemotherapy, but still, the cure rates with more advanced radiation and chemotherapy regimes are still reasonable. And, I always stress upon that it is very important that cervical cancer is picked up early and is treated appropriately. Many of these women, they just go to their local practitioners with complaints of bleeding, and without any investigation, without actually even suspecting malignancy, the uterus comes out. The woman undergoes hysterectomy. And after the pathology report, we come to know that either she's suffering from cervical cancer or she's suffering from uterine cancer. And then they are referred to us, oncosurgeons. And at that point, it is actually very difficult to treat her, whether to take her for second surgery or, to give her radiation. See, the window of opportunity is only so much. So I think we should always have this suspicion whenever a lady is presenting with abnormal symptoms. And one investigation or, biopsy, I think will not matter much and should always be done. So this is my concluding slide. Thorough clinical history and physical examination in every case is very important. Relevant investigations and imaging should always be done if there is a suspicion on a clinical history. Malignancy should be ruled out for all the cases, and oncology review or referral can be sought whenever necessary. First, do no harm, and this is for us surgeons that whenever there is a doubt, open the abdomen. Thank you so much, and thank you so much for this opportunity and patient hearing.
Thank you very much, madam. I can see one question. What is the criteria for HIPEC? So,
criteria for HIPEC is that we should be able to remove all the disease from the abdomen. So, a substandard surgery will never get compensated with HIPEC. Many a times the surgeons can feel that we will remove whatever we can And if even if there is some disease remaining behind, that can be taken care of by HIPEC. So that is absolutely not true. We offer HIPEC only when the disease is completely resectable, and it's R0 resection. R0 resection for cancer ovary surgery means that there is no gross disease remaining behind, because like I said, HIPEC can only treat the microscopic tumor cells. It cannot penetrate tumor nodules more than 2 or 3 millimeters in size. Other thing is, we pre-operatively we evaluate the lady completely. She should be fit. Renal function test, because this chemotherapy medicine is excreted in by the kidneys. Renal function tests, GFR, glomerular filtration rate, should be normal. We always explain that with HIPEC, there is still 5 to 10% risk of morbidity, meaning that the patient may have a prolonged ICU stay. The renal functions may get compromised temporarily. We may have to support the kidneys for temporary. The incidence of acute renal injury requiring dialysis is about 2 to 3% for all patients requiring HIPEC. So patient should be fit from her renal parameters point of view, and from surgery disease point of view, that the disease should be completely resectable.
Okay. Any comments on follow-up strategy of post-hysterectomy for endometriosis?
I think endometriosis after surgery is more of a medical management. Though endometriosis is not my area of expertise, but since this question has come, if for a lady we have done complete removal of uterus and ovaries, I think then the risk of recurrence of endometriosis is quite rare, because endometriosis is actually a hormone receptive disease. If both the ovaries has come out, then the recurrence risk of endometriosis is rare. Follow-up has to be more stringent when we have done a conservative management for a younger lady who's still requiring fertility, or who's still woman who's still young, and where we have done only ovarian cystectomy or some debulking of the peritoneal endometriotic nodules. And normally we put them on hormonal medications post surgery. Most commonly used is GnRH, leuprolide, and there are many other medicines. So basically these women will require some kind of ovarian suppression immediately after ovarian endometriosis surgery to prevent regrowth of the endometriotic nodules.
Finally, one question on cervical cancer vaccine. How effective it is in the prevention, and till what age you can advise you will advise this cervical vaccine?
15 years.
Yes. So studies which have been done have included women up to 46 years of age. So those trials which have happened for cervical vaccines, HPV vaccines, the women that have been included are up to 46 years of age. Whenever we are recommending this vaccine, many a times women in their 20s and 30s come that, okay, now we have recently married and we have recently heard about this HPV vaccine. So now can we take it? So we always tell them there is no harm in taking it, but we at the same time we reinforce the importance of cervical cancer screening with pap smear in them, because we always tell them that efficacy of this HPV vaccine, when we are giving in older women in their 20s, 30s, 40s, cannot be expected to be as good as when we are giving this vaccine in the adolescent girl. And hence we always tell them the importance of cervical screening also. It is not that a 45-year-old lady will take the vaccine and will think that I never have to undergo screening and I'm completely cured, saved from cancer cervix. That is not true. So we give them vaccine because women up to 46 years of age were included in the trials. So up to 46 years we can give, but at the same time, we should reinforce the importance of pap smear and HPV screening in them.
Thank you very much, Dr. Richa Bansal, madam. It was a very excellent lecture and very informative.
Thank you.
Yeah. Over to Dr. Usha.
Yeah, thank you, Dr. Richa Bansal, for giving excellent information about the gynec oncology.
Thank you, ma'am.
Now
My
we'll-
pleasure.
Yeah, thank you. Now we'll move to the next speaker, Dr. Rushi Deshpande. Is a well-known nephrologist in South Mumbai. I request Dr. Anil Awad, IMA President-elect, to introduce Dr. Rushi Deshpande. Over to Dr. Anil Awad.
Yeah. Thank you, Dr. Usha, ma'am. It is always a pleasure to introduce Dr. Rishi Deshpande, sir. He is the Director of Nephrology and Academics at Jaslok Hospital and Research Center and Director of Critical Care Nephrology at Sir H.N. Reliance Foundation Hospital and Research Center. After his MBBS and MD, he completed his DNB Nephrology and DM Nephrology. He received gold medal in DNB Nephrology awarded at the hands of President of India, Dr. APJ Abdul Kalam sir. He completed clinical fellowship in nephrology followed by clinical fellowship in renal transplantation at the University of Toronto, Canada. He has been trained in the management of patients with various renal problems such as acute renal failure, chronic renal failure, hypertension, nephritic syndrome, acid-base and electrolyte disorders, CAPD and transplant patients. He has presented multiple papers at various national and international conferences and has several publications in peer-reviewed journals to his credit. His areas of special interest are peritoneal dialysis, across blood group kidney transplantation, and marginal donor kidney transplantation. Today, he will enlighten us on when to go for kidney transplantation. Over to you, sir.
So thank you, Dr. Anil Awad, for a very kind introduction. So today, actually, we are going to talk about something relatively more basic for this audience. So, is my screen visible?
Yes, sir.
Yes.
Okay. So we have spoken about kidney transplant in the past. So, but today is more like going to the basics. Even now, I sometimes get this question: is my patient better off on dialysis, or should they really go for a transplantation? And so I thought that it's still a good idea to come back and visit this topic again. So when to go for a kidney transplantation? So this is a basic slide of the kidney. A kidney does much more than removal of waste products. And anybody who thinks that they are passing urine and so they don't need dialysis adequately needs, whenever they come to you and they say, doctor, see, I'm passing so much urine. Can I not do dialysis once a week? Can I not do it twice a week? Why should I go 3 times a week? Please tell them that your kidney is not just removing the waste products, it is doing a lot of other functions. It is not just about managing the extra fluid balance. It is about correcting the acid base, managing the blood pressure, and that cannot be done by anything else but by doing adequate dialysis. So this is what is seen world over now. This is US data, but India mirrors this. The incidence of end-stage renal failure is only increasing world over. Kidney disease, as we all know, is silent. Some of the patients could present to us with these symptoms like passing less urine, swelling all over the body, shortness of breath, feeling drowsy, fatigue, nausea. Some unfortunate ones could present with convulsions, or they could be brought in a comatose situation. But most of them, as you know, they are actually unaware till an advanced stage of the disease that they actually have a kidney problem. And that is why it is so important that these people have preventive health checkups to diagnose the problems early so that we can actually help them better. But once you develop end-stage kidney disease, what do you do next? What are your options? So these are all the options possibly available to a patient today with kidney disease. And that is either you go and do some form of renal replacement therapy, or if you are, suppose say you are 90 years of age, I don't believe that we should actually push everybody, or if they don't have any quality of life, a terminal malignancy patient with metastatic disease who doesn't wish to go for an extension of life, then, and there is an advanced care plan in place, we should also have a heart to say, okay, that you need not go for dialysis. But the rest of them who wish to live further and who have, they should be planned for some form of renal replacement therapy. And the ones available are dialysis, hemodialysis, peritoneal dialysis, and transplantation. And we need to help the patient choose between the three. So there comes the role of pre-end stage kidney disease planning, discussing the available options, planning in advance, whether they are going to go for long-term transplant or dialysis. And we should recommend not to delay the therapies for some life-threatening complications to set in or for an emergency to set in before they go for either of them. They should have a plan in place and they should start before the problem comes up and not after a complication sets in. This is what we know, that once you start dialysis, the probability of survival over a longer period of time, yes, it goes down, but dialysis does increase your years of life, right? So this is not a treatment of choice. This is a treatment because it gives you years of life after your natural life is over. So, but when you compare it to the other treatments, how does it fare? So when you compare dialysis, life on dialysis, it is actually like a life for somebody who is having, say, treatment for malignancy. That is actually how it should be compared to. So this was a Canadian data published in 2019 that showed a 10-year survival for all-cause mortality, where the patients on maintenance dialysis, they fared equally to the patients who were being treated for malignancies. So that is how dangerous it is. We sometimes get into this false zone of complacency where we feel, oh, okay, you're on dialysis, you'll live very long. That's not actually very true. Okay, this is what actually happens to these patients. However, if you compare to transplant, look at the yellow line at the bottom. So compared to dialysis, which is the blue line on the top, the transplant patients, the incident of death is much lower, over a longer period of time. So this data is actually over 15 years, and it does show us that compared to dialysis, the transplant patients survive much longer. So comparing the three options available does seem that transplant not just gives the patient a better quality of life, but also a prolonged survival advantage. So what is it when we talk about transplantation? This is a common diagram that all of you have seen. This is a donor kidney on the left, which along with the artery, vein, and the ureter is implanted into the recipient. So the recipient has two non-functioning kidneys and one good kidney, which is kept in the pelvis and anastomosed to the bladder, correct? The native kidneys, the non-functioning kidneys are usually not removed unless they are infected or they are having a malignant potential. Otherwise, we normally leave them alone. So it's a surgical procedure where it is placed usually in the right lower quadrant, sometimes in the left, and on examination, it is easily palpable, the transplant kidney. It is, like I said, the most effective therapy. It has a better long-term survival and improved quality of life compared to dialysis. The benefits are significant reduced risk of mortality compared to dialysis. The life expectancy is actually 3 times as better as dialysis. So 3 times, like 300% or triple the life expectancy. It reduced risk of heart attack, stroke, post transplant as compared to dialysis, improved quality of life, and more likely to stay employed. Very relevant in our scenario, where if the bread earner is the patient, then if he or she is not employed, that could become a big strength on the family, because the support systems here are not so robust. Well, transplant is not actually a bed of roses. There are risks. The main risks are of the graft getting a rejection, the transplant kidney. Even though it is less with the current medications, it is not zero by any means. The other problem is the risk of side effects with the anti-rejection therapies, and that includes infections, the risk of getting new onset diabetes, blood pressure, lipids, so high cholesterol is common, and over a longer period of time, malignancies can set in. So they need to be watched for and treated effectively, all of these risk factors, to avoid any problem to the patient. And over a longer period of time, even though they live 3 times as longer as dialysis, ultimately after 15 years, so currently the average half-life of a transplant kidney is 15 years, which means that after 15 years, 50% of the transplants that you have done today will not be working. So that is a fact, okay, that we need to understand when we counsel a patient for transplant. As of today, that remains the best treatment in place and the benefits far outweigh the risks. So when you compare head-on dialysis to transplant, this is what it looks like. So what does dialysis do for you? Dialysis does what a normal kidney does, 10 to 15% of it. So if your normal kidney is say working at 100%, then your dialysis 3 times a week, 4 sessions, 4-hour session will give you 15% of that function, only 15%. Whereas a good functioning transplant kidney can give you anywhere between 50 to 75-80% based on how much hypertrophy it can get over a period of time, but at least 50%. On dialysis, you will have a lot of restrictions. So you'll have to follow a rigid diet plan. Whereas post-transplant, if the kidney is working well, then at least the fluid restrictions will go, even though the dietary restrictions in terms of salt and calorie intake and sugar may remain, but at least the liquid intake restrictions will go. Dialysis patients typically have restrictions in terms of energy levels and ability to work, which are much lower in patients who have a successful transplant. So patient survival rate, this is what I was talking to you about. So the red line on the top is a transplant. So if you see at 5 years post-transplantation, more than 80% of the patients are active and alive and doing well. And whereas at 5 years on dialysis, almost 50% of the patients are either not alive or having some serious problems. So that is how bad it can be. This data is from Biostatistics and Epidemiology Journal 2018. So cost of dialysis versus transplantation, very important in our scenario. So the initial cost of transplantation is definitely high. So this is in US dollars. So this is American data. The Indian data, the numbers will change a lot. However, the graph will remain the same. So if you look at the graph, the two charts, the faint green line and the blue line. The blue line is the dialysis line and the faint green line is a transplant. So the transplant initial cost in the first year is almost 2.5 times that of dialysis. Whereas at the end of 2 years, the graphs are now become same. So what it means is that at the end of 2 years, whether you are on transplant or you have done a dialysis or you are on dialysis, your cost has more or less remained the same at the end of 2 years. However, after 2 years, if you continue having a successful transplant, then your cost goes down. And every extra year that you live with a good transplant, you save money. That is what the data shows. So successful transplant will save you money after 2 years, not in the first 2 years. So this is for all patients, whether you are doing in-center dialysis, whether you are doing peritoneal dialysis, whether you are doing home dialysis, whether, and like in transplant, I said, whether, every second, after the second year, the benefits, economic benefits will start becoming more obvious. The first year, there is no, till the end of second year, you can't show any economic benefits with transplant. So who can undergo a kidney transplant? Actually, there is no absolute age limit to which patient can undergo a kidney transplant. Any patient on dialysis, my personal belief is, if I'm using a living donor kidney, or for that matter, any donor kidney, then the patient should at least have a 5-year life expectancy if I'm going to use a kidney for him. That being said, if somebody wishes to have a kidney transplant and the donor wishes to give him a kidney, I don't see how I can say no to that. Absolute contraindications like an active infection, an active malignancy, or any cardiac or lung condition or a vascular condition that would be making him unfit for anesthesia, those are patients that you would not transplant. You would just say, no, I cannot transplant you. Non-compliance is a serious issue. So a patient who is not going to take medicines regularly after transplantation, you better say no at the outset, unless you can be assured that they have changed and they are really going to take the medicines, or somebody else is going to take responsibility for the medicines lifelong for them. Okay. What were contraindications in the past are now relative contraindications or no contraindications. I mean, see, HIV, all of you know I did 4 patients with HIV I've transplanted 4 patients with that. Hepatitis B and C, so we are doing so routinely, we don't even talk about it. Blood group, the first time I did a across blood group transplant was 2008. So last 13 years, we have done blood group, across the blood group transplantations as if they are routine, we do it now, right? So what the contraindications once upon a time, like for across, like, primary oxalosis, which was like an absolute contraindication. Now we are overcoming it by doing combined liver kidney transplant, of which we have already done 2 so far. So pre-transplant issues to consider: cardiovascular disease, infections, malignancies, psychosocial factors. Immune function is very important. Some other day we'll discuss that. Next Sunday, actually, yes. I would, I'm sure I'll send a link to all of you who have attended the program today to attend our program next Sunday, where I'll be speaking on how immunology of transplantation has evolved over the last 50 years, and how we as nephrologists are tailoring immunosuppression, the medicines that we use post-transplantation. And it is not one therapy fits all anymore. To each patient, we are able to give a different prescription based on their immunology screening. So we are able to decide who gets how much medicine. By that, we are able to minimize the complications that they need to suffer as a result of the side effect of these medicines. At the same time, prevent any rejections and maximize the kidney outcome. Okay. So this is an invitation for all of you to attend next Sunday, and you will all receive a link for the same. So types of donor: living donors and deceased donors. I am the chairperson of the Kidney Transplant Committee of ZTCC Mumbai. So that is a social obligation that I continue to do. And I am sure that all of you as family physicians see a lot of patients, and you are very important in our, what should I say, it's our mission to promote organ donation, and IMA has always been at the forefront. And please continue the good work and continue sending the message across that there is no use taking your organs to heaven, because heaven knows we need them more here for those poor patients who are on dialysis. So, any of your patients who can, or their loved ones who unfortunately, who are passing away, if they can donate their organs, or who wish, they should register as organ donors. That is a message that I would like to give at this point. Who can donate in our country? The laws are very strict. So there is a close relative. So the close relative means the hospital can give the permission without having to go to the government. So parents, brothers, sisters, children, wife, grandparents, grandchildren. So they come in the immediate circle of life, and here you need not go to the government for permission. The hospital can give the permission, the hospital committee. Anybody else, like an uncle, auntie, cousin, then it has to go to the government to establish that the transplant is above board and that there is no money transaction or no illegal thing has been done. As you know, we are very, very strict when it comes to following procedures, and we like everything to be above board. So then it is sent to the government, and only with all permissions we will do such a transplant. Only patients who are above 18 years can be considered as organ donors. Do no harm. That remains a motto of every doctor, and it should be. So pre-transplant donor evaluation should be done very strictly, ensuring that the donor is not brought at, there's no harm to the donor from the act of donating the kidney. That includes a physical checkup and a psychiatric checkup. Also, the recipient who's going to get the kidney should get the maximum benefit. So the GFR of the kidney should be good. The tissue typing should be done, and made sure that the matching of the kidney is good, so that the kidney will function well after the act of donation. And all the tests listed here are done properly on the donor. Any donor who is unfit, ideally it should be very, if you're ever going to take a donor with hypertension or impaired glucose tolerance, then you should do it with a lot of counseling, because that becomes your responsibility to look after them for the rest of their life and make sure that they don't become a kidney patient later. And to the donor, The thing is that they should be counseled that they should have a healthy heart diet, have a low salt diet, and they have a small risk of developing hypertension later in life. And they should make sure that they are following themselves at least once a year with blood pressure and blood test. So authorization, I have told you. When to go in, the timing of the transplant is very important. Like, people sometimes feel that they should start dialysis and only then consider a transplant. That is not true. Okay, the best time to go for a transplant actually is preemptive. Preemptive means preempt. Don't go for dialysis. When your GFR is below 15 and you have a living donor, go for a transplant. That is actually showing the best results world over, as I will show you. Right? So if you have availability of the donor, you should consider that. What are the benefits? The rejection rates are actually less by 25% in a preemptive transplant than after you start dialysis. The graft survival is better, patient survival is better, graft function, delayed graft function is less. And the patients who have a preemptive transplant seem to do much better in a lot of ways, including saving money. Understand? So preemptive transplant, once you're sure that your kidneys are not going to recover and that you are ultimately going to end on dialysis, why wait? Go for a preemptive transplant and you could be eligible for a lot of these benefits. If the blood group is not matching, well, like I told you, we to go in for ABO incompatible transplants routinely. I think nowadays, so every third transplant I do is across the blood group barrier. And that's not an overstatement at all. And so even though blood group matching or compatibility is preferable, if it is not there, it's just a couple of lakh rupees extra, and we are able to do by using these techniques of giving some medicines like rituximab and plasma exchanges, we are able to do it very easily. Swap transplants are great on paper, but in practice they are very difficult to do. Kidney paired exchanges, with given the logistics involved, it is far easier to do a across the blood group transplant than to go for a swap or a kidney paired exchange. So unless something changes very dramatically, I personally feel that we should go for an across the blood group transplant rather than, however, that being said, if a swap is on the table, will I prefer a swap or an across the blood group transplant? I will go for the swap. I mean, what I'm trying to tell you is that if a blood group, across the blood group transplant, if it can be avoided by doing a swap transplant where we have two pairs of incompatible blood groups willing to donate to each other, and they are available and acceptable to both of them. You have to understand here that these are people we are talking about. The donor and the recipient should be acceptable to each other. If they are, then you should go for a swap, because that will mean less medicines, less immunosuppression, less chances of getting infection. Other than that, the outcomes of ABO incompatible transplants are actually so good that from the medical point of view, I don't see a problem doing them at all. Okay, so this is how a swap is done, where if you have a donor A and a recipient of blood group B, and the other is a donor B with the recipient blood group A, then you exchange the donors, and that is called as a swap. Sometimes you can do multiple level swaps and help more donors. The KPD swapping at multiple levels helps people with desensitizations, particularly where they are not able to find donors. Advantages is the cost goes down because the cost of rituximab and plasma exchange goes down. That being said, when it comes to outcomes, the ABO incompatible transplant outcomes are equally good in our hands as compared to the ABO match transplants. Deceased donor transplants in our city, particularly, we should take pride in saying that Mumbai is having right now, I think, one of the maximum number of deceased donor transplants in the country as a city, and it's thanks to all of you. A good effort from all of us that the number of deceased donors in our city is increasing. We cannot sit on our laurels at this minute because there's a lot to be done. The waiting lists are a lot longer. Average wait times are 5 to 6 years for the patients. So a lot needs to be done. So, but this is the way to go. Okay. So brain death, I'm not going to talk about that. Rejection, a word on that. But basically, this is for next Sunday, where I'm going to tell you about how we adjust our immunosuppressive medicines and why how we avoid rejections. These are the different immunosuppression medications we have, induction agents and maintenance regimens. Some of you whose patients I have transplanted know that already. Tacrolimus, mycophenolate, steroids, sirolimus, everolimus are the common ones we use on maintenance. For induction, either we use an anti-thymocyte globulin, which is strong, potent medicine, or sometimes we use basiliximab if it is not a high-risk transplant. Important that you tell your patient upfront that the medicines post-transplant have to be taken lifelong. Do not give them any false hopes that the medicines will stop after 6 months, 1 year, 2 years, nothing. Please tell them upfront that the medicines will continue life. You can tell them that the medicine doses may reduce over a period of time as the risk of rejection lessens with time. That is true. However, the medicines will not stop. And because as of today, we are not able to induce tolerance in the patients. Stopping the medicine means the risk of rejection goes up. And if the patient gets a rejection late in the course of the transplant, he or she will lose the kidney. So please, it is our duty as doctors and your duty as family doctors, because these patients really trust all of you so much, that please tell them that they have to take their medicine lifelong. Follow-ups, I mean, we do that with your help, and what the weight, blood pressure, sugar monitoring, taking the medicines on time, and mask. I mean, all of us use a mask now, so what is there to say? Avoiding crowded places. Actually, post-COVID, what these transplant patients used to do, I think all of us are doing. So we are avoiding crowded places, we are using masks, we are not eating outside food. So I think life is, what they used to do, we are all doing now. So that's how it is. Logistics. So this became an issue in the COVID era because some of them had problems getting drug supplies. So it's important that we learn to tell them to stock themselves with 3 to 4 months of drug supplies. We never thought about this before, that we might actually not be able to give them the medicines on time. So that was important. So summarizing the presentation, the best treatment for end-stage renal kidney disease is kidney transplant. Kidney transplant saves lives, improves the quality of life, and saves money to the patient compared for this disease management particularly. Living kidney donation is safe and provides better outcomes than deceased donor kidney donations. Preemptive kidney transplant is the best option amongst the available treatment options for renal replacement therapy. Thank you, IMA, for the kind invite, and thank you for everybody who has attended. I can see 346 of you who have managed to come on a Sunday morning to listen to me. So a big thanks to all of you who spared your time to listen to this presentation. Okay, thank you so much as always for all the love and affection. Back to you, sir.
Thank you very much, sir. We have heard you from you so many times on kidney transplantation. There are 2 new questions I can see. Can a healthy transplanted kidney be redonated after the death of that person?
Very good question, sir. The answer is no. This has actually been debated in transplant forums in the past amongst transplant immunologists.
Yeah.
Because what it is impossible to fathom what would happen to the transplant kidney once it has been transplanted. Because immunologically, once a transplant kidney is implanted into another individual, at the level of the DNA, there is some kind of a microchimerism that is happening, trying to make this kidney a part of the human body that it has been implanted into. And that is not understood by our immunologic techniques at the moment. So tomorrow, if you are going to take this kidney out and put it into another individual, you have no idea what you are trying to do. Because as it is, you had 6 HLA antigens at the outset, and now you have 6 more from the person that you have implanted into. And now you are going to put it into another person. So far it has never been attempted. Whether it can be done in the future, it is something that has never been explored, because that would open a Pandora's box. Well, it is something, let us say that it is not beyond the realm of possibility that it should never be done, but as of today it has never been.
Okay. There's one more question. If a patient is already on dialysis, can he go for renal transplantation?
100%.
Yeah.
at any time during dialysis. I mean, normally see patients who are getting the cadaver kidneys, the deceased donor kidneys, they are on dialysis for 5 to 7 years before they get their transplants. An average wait time. Sometimes patients are on dialysis 10 years before they get the kidney. So there is no time on dialysis that stops them from getting the transplant.
So the role of pygenal in BPH, is it really helpful?
Which one, sir?
Role of pygenal.
What is that?
It's a medicine. PYGINAL.
PY? Let me just see what it is, sir. Yeah, what is it? PY? Just Google it. What does it contain? So it is coming out as a Africanum soft gelatin capsules. So no idea. This is not even a medicine you ever prescribed.
Even I am not aware.
It is some kind of a, not a traditional medicine. It looks like a nutraceutical or a alternative specialty.
Yeah.
Not something that we have ever tried or used or ever seen in literature.
Any other question from the panelists? What about preoperative tests for donor kidney who has already died?
For deceased donor transplant, you mean, sir?
Preoperative test for donor kidney who has already dead.
Yeah, so that is a deceased donor. So a donor who is a cadaveric donor, brain dead donor. So see, there are tests of two types here. First test is test to confirm the brain death. So that is done by a panel of neurologists and intensivists. So there are two tests done 6 hours apart to confirm the brain death. That includes the EEG and clinical tests to confirm the brain death situation. And then there are tests that we request for from the ZTCC to confirm that the organs are in reasonable condition to be donated. And by that we mean that the kidney function is good. So we request for an ultrasound to be sure that the kidneys are structurally good. Then we would request for a urine to make sure that the patient is not having an active urinary problem like an infection or protein or blood in the urine. That the patient is diabetic or non-diabetic. What is the creatinine of the patient? What is the creatinine clearance of the patient? So in a deceased donor transplant, we actually request for very basic tests. We don't request for something like a DTP renal scan or a donor angio, because here the safety of the donor is not at concern. Because here the donor is brain dead, correct? So here the safety of the donor is not at concern. Here the only concern is, are the organs good quality so that they can be distributed? Are the patients going to benefit from these organs? So the thought process is different when you are donating from a cadaveric donor as compared to a living donor. In a living donor, that living donor has to live for the next 50 years, 100 years. So you have to be sure that the living donor is not going to become a patient. So the tests are of a different type. In a deceased donor, you just have to be sure that the organs are good, they are not carrying any infection or cancer, and they have good function, so that they can be transplanted.
A very interesting question. Can a transplanted patient be retransplanted if rejection has taken place?
Definitely yes. So the maximum number of transplants that a patient has undergone so far is 4.
Oh.
So 1 kidney in the right, 1 kidney in the left. So when they were needed to put a 3rd kidney, they removed one of the native kidneys and put a 3rd one there. And when that rejected, the 4th kidney was put by removing the native kidney on the left. And this patient, mind you, lived 40 years from his first transplant. 40 years. Okay. So by doing this, he was actually able to survive 40 years of extra life by going through 4 kidney transplants.
Maybe the last question. What is the approximate cost for the procedure of RRT on an average?
See, Mumbai dialysis is from 100 rupees to 3,000 rupees. Kidney transplantation is average 6 lakhs to 10 lakhs in an economy class. If it's an across the blood group transplant, it's 8 lakhs to 11 lakhs. So it all depends on how thick your wallet is.
Yeah, yeah.
And also depends on what quality you are looking for and everything like that.
Sir, what should be the earliest marker to start dialysis?
World over, the eGFR is what we go by. So eGFR less than 15, you should start preparation for RRT. eGFR less than 10, you should start dialysis. Do not wait for absolute symptoms to happen before you start dialysis. So even though you may say, oh, I am feeling okay, I am passing urine. Also, diseases are different. What is it? The disease is very important. A diabetic with the eGFR of 10 is bound to feel sick and say, please start my dialysis. A polycystic kidney patient with a GFR of 10 will say, well, I can wait for 6 months more.
Yeah.
Because the rate of fall of eGFR from the past will tell you how much time he or she is going to get. Somebody who is losing GFR at the rate of 1.5 per month is not going to carry on for too long. Whereas somebody who is losing eGFR at the rate of 1 or 2 ml per year can carry on for much longer. So the primary disease is very important.
Yeah. Thank you very much, sir, for an excellent presentation. You are always good as usual.
Thank you so much for the kind invite. Bye. Thanks.
Bye. Dr. Usha.
Yeah, thank you so much, Dr. Rushi Deshpande, for giving wonderful information about the kidney transplantation. Now, shall we go for the next speaker?
Yes.
Now the next speaker is Dr. Rahul Verma. He's a consulting neonatologist and pediatrician. I request Assistant Secretary CGP Sub-Faculty Dr. Kajal Ahuja to introduce the speaker.
Dr. Rahul Verma is consultant and head neonatology department and consultant with the pediatrics department of Sir H.N. Reliance Foundation Hospital and Research Center. After passing his MBBS from the University of Mumbai, he acquired a diploma in child head DCH from College of Physicians and Surgeons, Mumbai. Then he did MD Pediatrics from Mumbai University, followed by MRCP Pediatrics from Royal College of Physicians in UK. He has been consultant and head department of neonatology and consultant in pediatrics at Bombay Hospital and head of neonatology with Wokhart and Seven Hills Hospital. He has several dissertations and publications to his credit, both in national and international forums. He has also been a teacher and a guide for DCH as well as DNB Pediatrics. He is a visiting scholar with Babies and Children Hospital at Columbia Presbyterian Group of Hospitals, New York, USA, and visiting fellow at Regional Neonatal Referral Unit, King's College Hospital, London, UK. He is a joint secretary and treasurer of Maharashtra Chapter National Neonatology Forum and vice president Neonatology Forum, Mumbai. Today, he'll be speaking on pediatric emergencies. Over to Dr. Rahul Verma.
Thank you very much, Dr. Kajal, for that kind introduction. Good morning to everyone. And I think without wasting any more time, I shall move on to my presentation. I hope my slides are seen.
Yes, sir.
Okay, thank you very much. So we'll go on. Pediatric emergencies is actually a very broad spectrum of syndromes and disease processes. And what matters is what is the timing when which the child is referred to us in the emergency services or directly to the OPD, or if the parents bring the child to our clinics at any given time. They roughly account for around 1 in 5 to 1 in 10 patients of visits to the emergency. So we usually see around 10 to 20% of children visiting our emergency with various issues. The commonest emergencies, of course, are any breathing issues, dehydration due to diarrhea and or vomiting, anaphylaxis, seizures, trauma, and of course, in infants, excessive crying seems to be the commonest reason why a baby is got to the emergency or to the clinic. In older children, of course, we see unconsciousness as one of the important issues why a child is rushed to the emergency. The child may be in shock, may have evidence of airway obstruction, cardiac emergencies. We have a very big pediatric cardiac unit. So many of these children come in pre-op or post-op also, depending on what is the emergency. Children may present with seizures, pain. Abdominal pain seems to be another issue, why we see a lot of children coming at various times. And usually it's in the evenings when the parents, or at least the father comes from work and the mother complains, child is having abdominal pain, and that irritation, instead of coming to the normal clinic, then the child is then rushed to the emergency services. There can be environmental factors also, for example, ingestions or aspirations of various things, injuries and allergic reactions or anaphylaxis, which becomes very life-threatening at times, and very, very rarely drowning situation. So as you can see, the X-ray on the side, we have a child who's presented with a foreign body ingestion, luckily not an aspiration, but an ingestion. And I think here we had to move in quite rapidly and sort things out. As compared to older children, newborns and infants may have a slightly different variety of emergencies. They usually come in with excessive crying, refusal to feed, which become very, very important. Bluish discoloration, which is cyanosis, central or peripheral, not breathing, and that becomes extremely concerning and requires severe emergent processes. Seizures is another thing, and of course, bleeding. Commonly, newborns bleeding from the umbilical stump becomes an important thing. As you can see, this baby on the side is actually having a convulsion. This is the third episode. Luckily, in this baby, we found that it was just a calcium deficiency which was causing the convulsion, but there are many other causes which can be quite relevant and require further treatment. So we'll start off with a few emergencies. I cannot cover a lot of emergencies, but let's look at an unconscious child who's got to the emergency. So we do have a lot of causes. The two commonest causes for an unconscious child would be post-convulsions, that means post-seizures, whether it is the first episode or a child known to have recurrent seizures. And the other one would be trauma. So any child who's playing, falls down, hits his head and becomes unconscious. So these are the two commonest. There are, of course, many other causes for a child coming unconscious, and we need to have a detailed examination starting from head to toe, and need to rule out things after ensuring that the child is stable and his vitals are established and whatever support is required is given. So you can see a lot of causes over here. The important two things which we need to look at is in older children, of course, we do a Glasgow coma scale assessment, which actually tells us the severity of the problem. And the other thing is doing a blood sugar. So every child who comes unconscious, once you've stabilized the child, usually the first test one would love to do is a blood sugar, because there are many children who either become hypoglycemic, low blood sugars, or even worse would be hyperglycemic. So they're actually presenting as the first episode of diabetic ketoacidosis, which is a very underdiagnosed situation in our situation. So we need to do a blood sugar, and of course, we need to look at other causes why this child is unconscious. Very important before you look into the causes, as I said, stabilize the child, make sure that breathing is established. If the child is in cardiac arrest, then we need to resuscitate the child and stabilize the child, and then take the tests further. So that is as far as the unconscious child or an infant goes. One of the commonest reasons why we have children trickling into the emergency, and that is those with acute respiratory symptoms. So these symptoms can be either due to upper airway, it could be lower airway, or it could be because of the lung parenchymal disease itself. Various causes for obstruction to the upper airway, large tonsils, adenoids, croup is a very, very important cause and can become life-threatening at times. And sometimes children are gotten quite late with croup. So croup actually is a viral infection. So usually you'll have a history of fever. I think I have, so let me go into croup later on. We look at, depending on the distress, we can try to assess where exactly is the source of the distress, whether it is the upper airway, whether it is the lower airway, or whether it's the lung parenchyma. So if you have inspiratory stridor, usually means that the upper airway is involved, and that becomes a good focus to look at. We may have a barking cough, we may have hoarseness of the throat, and you will have what we call suprasternal tugging. So all of these suggest that actually the problem is in the upper airway. If we have a child presenting with a wheeze and it is expiratory or with a prolonged expiration and subcostal recessions, then obviously this is the lower airway. While if you have a baby who's grunting, has got widespread or localized crepitations, reduced air sounds, which becomes an emergency because absence of air sounds can be an impending situation of pneumothorax or a very severe bronchial asthma, and intercostal recessions, which help us in deciding that this is more of a parenchymal problem rather than an upper or a lower airway problem. So this is a 3.5-year-old child who had presented in the emergency with a barking cough. So crew basically means a hoarse voice or a hoarse cough. And it's very significantly picked up. You don't have to touch the child or stimulate the child too much. But if you do an X-ray, lateral and AP, you'll find narrowing of the upper airway. So if you actually see where the arrow is pointing out, you'll see a steeple sign, which is a narrowing of the upper airway, which is the commonest cause for or the commonest sign that we see in crew. It can be mild or moderate. The idea is not to panic over here at all. Reassure the parents. We do nebulize children with established crew with adrenaline, and we can give oral, intravenous, or intramuscular steroids. We observe the child usually in the emergency, and if it is very, very severe, where the child requires some support as far as the respiratory system is concerned, then we obviously need to admit the child and take things further. So crew is a very common thing. Usually, parents tend to ignore crew because it's just a dry cough initially coming up, but then with the spike in fever and the severe breathlessness makes them rush to the emergency at their fastest. The next thing which we have seen in infants, especially smaller ones, is bronchiolitis. So these are children who have a mild nasal stuffiness or a running nose, suddenly have fever and then become breathless. So this was actually a set of twins who came to us in the emergency just around 10-15 days back. And the twins, both of them were having evidence of respiratory distress. The twin on the left-hand side with the bad X-ray actually had almost a cardiac standstill, needed to be resuscitated and rushed to the intensive care unit. The baby on the right initially was fine, but of course became a bit bad after 24 hours. Luckily, in the ICU settings, both of them were very comfortable. And after 4 to 5 days of just supplemental oxygen and IV fluids, we were able to get them off their supports. And as we speak today, they're getting discharged after 9 days. So bronchiolitis, though it in the textbook seems a very light thing of just, hawa pani ki zarurat hai. However, we do have incidences. Coincidentally, we did the throat swab in this baby, one of them, and it came out to be RSV positive. Now, the issue, of course, here was if these babies were at home, what was causing the respiratory distress? So, and how did the baby get the infection? But then, of course, as Rushi said in the previous lecture, I think mask becomes important not only for COVID also, but for many other infections, especially in smaller babies. So this was bronchiolitis. We go on to asthma, which is going to be another common presentation in older children, or the first episode of breathlessness. Now, unlike adults, it is very important to understand that asthma presentation is not always breathlessness or a wheeze, but actually severe coughing in the night, sufficiently alarming to wake the child up. So that is how usually they would present to us. These children, especially the first episode, becomes a bit concerning, and we need to move very quickly and try to get the inflammation and the obstruction down to a sufficient level whereby they can then go on to a regular maintenance medicine and be observed and monitored for further things. So severe asthma would present with severe respiratory distress. There will be tachycardia, saturation will start dropping. The child will require supplemental oxygen, is not able to do a single breath count so easily, is unable to walk around without having to stop for breath. And of course, in severe respiratory distress can become confused, restless, or irritable. So here we obviously need to give some supplemental oxygen. do remember, we do not over-oxygenate these babies. We give only sufficiently to maintain a saturation of 94 to 95%. We do nebulize the children, so we can use a short-acting beta agonist, and we can use steroid inhalation. Both of them would be good enough to at least attempt to stop this acute exacerbation of breathlessness. So obviously, few children would obviously require admission and further management. But the first episode of asthma is very important because A, we try to find out the cause, and second is we need to monitor these children for longer duration since they may have recurrence of breathlessness. So essentially, when we look at respiratory emergencies, any child who presents in the clinic with tachypnea or respiratory distress. So tachypnea is just an increase in the breath rate, while distress is an increased use of accessory muscles of respiration, may or may not be tachypnic, especially if the child is severely distressed and is actually getting tired, will actually have much slower breaths than normal, very concerning for us. Chest indrawing, severe cough, cyanosis. Now, because of COVID, thankfully, everyone is moving around with small little pocket pulse oxes. And I think it's a good idea to keep a pulse ox in our clinic or even in our pocket nowadays, especially if you're moving in between hospitals, so that an objective parameter besides just being breathless can be actually measuring the saturation and directing the child towards more emergent care unless the saturations are absolutely fine. Smaller babies may be too sick to feed. They have refusal of feed. So all of these then should make us understand that this baby is not normal. If you hear a wheeze, if you hear crepitations, that's fine. But as I emphasize, if you have a silent chest, then this child may be in impending respiratory failure or has an acute situation like a pneumothorax and will require referral to the emergency system. Coming on to excessive crying. So infants especially are very, very cranky, especially in the evening. I call it the devil's time for newborns and young infants between 6 p.m. to 2 a.m. So most of the babies just will cry with no reason whatsoever. The parents call up the pediatrician says, don't worry at all, this is just colic, you relax. But then every cry is not a colic. We need to remember that to define colic, we need to have an apparently healthy baby who's crying for at least 3 hours in a day, for at least 3 times in a week, for at least 3 weeks to be properly defined in the absence of any other problems to be defined as having colic. So every baby infant crying is not a colic. An older child crying definitely is significant because that suggests that he or she is in such pain or in such distress that obviously we need to find out more as to what is happening. There are multiple other causes of excessive crying. In an infant, the causes are more like intussusception, ant bites. We have seen multiple ant bites. When we open up a baby, the back is covered with ant bites, which also causes excessive crying. Many of these babies can have an anaphylactic reaction because of the numerous bites. So we need to exactly find out the cause of the crying. Older children crying actually would be able to tell you why they're crying if they're old enough, or at least point out what is troubling them. So whether it's an abdominal pain, whether it's a throat pain, whether any arm is hurting, but infants would not be able to point out the location or the source of their pain and cry, and hence have to be evaluated very systematically from top to bottom. Coming to GI emergencies, we have vomiting. Now, most of the babies do tend to posit or spit up, as we call it, which is usually a small amount of curdled milk after a feed, or especially during burping. That is quite normal. But if you have any child, especially older children who are vomiting, then we need to make sure that we find out the cause of the vomiting. Younger infants persistently vomiting to a point where they almost become listless and have refusal of feeds obviously require emergent care. We do find that in older children, the commonest cause of vomiting should be gastritis, whether it's infective or non-infective. And we can appropriately manage them by doing a full examination, offering them pain relief, and we can also offer them an anti-emetic like ondansetron or even simple domperidone. But if you go into the detailed history, you may find that actually most of these children are coughing excessively and then vomiting. So obviously the primary issue over here is not the vomiting, the primary issue over here is the excessive coughing. So we need to be very careful that we do take a detailed history to find out whether it's a post-tussive coughing, where we need to address the respiratory system, vis-a-vis a primary vomiting, which may be most probably either infective, non-infective, but a gastritis-like situation. Other more serious situations like pyloric stenosis, intussusception, non-GI causes of vomiting. For example, any meningitis may also present with a lot of vomiting. The textbook says projectile vomiting, but let not be so. So any child with fever and vomiting obviously will have a different evaluation as respect to a child who's just vomiting once or twice. Many times on the history, you'll find that they've eaten something new, mushrooms or peanuts or something new which was not previously, or they've eaten outside. Then it becomes a bit more reassuring that this is more because of gastritis rather than because of any other cause. But most of these have to be evaluated properly. And of course, we need to keep an eye on their hydration, because after multiple vomits, the child will not accept oral feeds and actually go into dehydration. The other thing is usually is if it is gastritis, it may lead to gastroenteritis. So vomiting followed by diarrhea, more the reason to look out for dehydration in this child. So coming to diarrhea, multiple causes. Usually a transient diarrhea is infective or because of food poisoning. We need to assess such children very, very carefully. For me, the single important test is the capillary refill, or what we used to call the skin turgor test. If the refill is less than 2 seconds, it's very reassuring that this is mild dehydration. But anything more than 2 seconds associated with dryness of the mouth, absent tears, obviously indicates that the intensity of dehydration is almost grade 3. That means more than 10% dehydration. And these children need to be at least kept in the emergency to rehydrate them, assess them for ongoing fluid requirement and fluid loss, and if required, need to be admitted for further management. So this is how we go: minimal dehydration, we continue oral feeds. An important thing about diarrhea is, unlike olden days, we do not stop normal diet. We encourage normal diet, including milk, for acute diarrheas, because we believe that whatever the child actually passes out, still you give sufficient energy to be able to fight out any infection and maintain your body fluids. So small, frequent feeds are very important. If the child is more than grade 1 dehydration, then we can, of course, offer oral rehydration solution, which is the low solute one now. So sodium is 20 milliequivalents, not the classical cholera ORS, where you used to have a very high amount of sodium, because hypernatremia becomes a very common situation in children who are given excessive sodium. So normal food intake, of course, ensuring that we give some antiemetic if the child is also vomiting, small frequent feeding, and fluid rehydration. These form the basis of sufficient treatment. In very severe dehydration, obviously, if the child is not taking orally, or we have low blood pressure, thready pulse, tachycardia, then obviously these children need to be admitted and provided with intravenous fluids so that we can get them back to a normal hydration. Most of the gastroenteritis, we do advocate very routinely use of probiotics and oral zinc. So do remember that if a child has repeated episodes in a month of 2 or 3 episodes of gastroenteritis, which we have seen, sometimes over-treatment with zinc also occurs. So we do need to take a story that, have you received any zinc supplements in the last 2 weeks, in which case you may not repeat it, but just treat it symptomatically as far as the fluid is concerned. Tummy pain is the bane of our life, morning, afternoon, evening, night. You will always have some mother calling up or some parent calling up, my child has tummy ache, what should I do? This becomes a very concerning thing, because 90% of them are talking to you on the phone. So you really do not know what is happening. If it is a simple tummy ache, I usually remember one thing, that if the tummy ache is more around the umbilicus, hopefully it is a benign situation, self-limiting situation. But if the ache is moving away from the umbilicus towards the periphery, this child needs to be seen and examined. So any pain which is spasmodic and moves away from the umbilicus, associated with vomiting, diarrhea, associated with bilious vomiting, such children need to be examined physically, cannot comment on the phone at all. But simple things like, my child ate too many chocolates today and vomited once or twice, you can reassure them, give them some pain relief, usually Colicade or anything which contains cyclopam, mild dose can be given once or twice. If the pain persists beyond 6 hours, this child will need to come to the emergency for a further evaluation or to the clinic for further evaluation. So very important to understand transient abdominal pain, more around the umbilicus in a child who's otherwise fine, do not worry at all. But if the pain is moving away from the umbilicus with persistent vomiting and or diarrhea or any other signs, I think it becomes very important that such a child be examined appropriately and steps taken to ensure to find the cause of this tummy pain. Next is seizures. So luckily in children between 6 months to 6 years of age, the commonest cause of seizures would be febrile fits. That means at the onset of fever and at the climb of the fever, you get the onset of fits. Usually they're tonic posturing or clonic movements, which last usually for around 30 seconds, maximum to a minute, followed by a altered sensorium for about 20 minutes to an hour. So this is classical febrile fits. So there has to be history of fever coming up. Most of the fits, if the child is afebrile, post fits will definitely have a spike of fever because of increased muscular activity, especially in the tonic-clonic situation. So we need to be careful. We do realize that the child is at the onset of fever, usually prior to the fits rather than after the fits. Usually when you have a febrile fit, it should not be repeating in the next 24 hours. If it does, and we have ruled out all other causes, then they are termed as atypical febrile seizures. There are, of course, other causes of seizures, especially in the absence of fever or in the presence of high-grade fever. Any infant who's less than 1 year has the first episode of seizure, ideally, should be admitted for a proper evaluation and observation. Most of them with fever would invite a lumbar puncture. Many a times, if the child is otherwise fine or has a past history of convulsions, because of febrile fits, we may not do a lumbar puncture, but we can actually observe them for 6 to 8 hours. Older children, definitely we don't need to worry too much because they will definitely indicate and your examination will find out some cause for the seizures. It is very important if a child is on anti-seizure medicine and comes with seizure, we need to take a detailed history of whether the medication was being taken regularly or not, or was there any other trigger which has further increased the seizure? Because pleomorphic seizures can occur where you start off with one type of seizure and ultimately land up into another type of seizure where the anticonvulsant required is going to be different. So this is all about seizures. First seizure, usually, since we are not aware of the cause or we cannot ascertain immediately, we stabilize the child, we can stop the fit. If we have IV access, if we do not have, then midazolam sprays are available now for intranasal use, or you can use midazolam per rectally also to terminate the seizure and make sure that the child is stable. Once the child is stable, we can draw bloods, take the history, and of course, take it further as to ascertaining the cause of the seizures. Allergies and anaphylaxis is very important and very, very difficult situation. It can be very life-threatening also. So usually after eating something, smelling something, playing with something, or being bitten by something is when a child will start with the so-called allergic reaction. Mild reactions would usually be some urticarial rash, a bit of swelling around the eyes or the lips, as you can see in the photograph over here. But if the allergy is significant enough or may lead into anaphylaxis, then of course respiratory embarrassment because of edema of the upper airway is very important. We need to stabilize such children. We need to make sure that we take a proper history. Now, usually if there's an insect bite, we do try to figure out whether it is food related. For example, someone has had mushrooms for the first time, and the child then, after 2 hours has severe abdominal pain, may have diarrhea, and then start bloating up physically. So we do need to take a proper history. Sometimes because of the allergy itself and the vasodilatation, the child may have a syncopal episode, and that also we need to be very careful about. So usually for an emergency, adrenaline, antihistamines, and steroids are the 3 pillars for treating the emergency. Once we document that the allergy is because of a specific substance, we need to advise the parents to keep the child away from that substance and take things further and monitor things. If a child has settled down after the first episode of angioedema or severe allergy, it is recommended that the child remain for 24 to 48 hours in the hospital, because you may have a delayed reaction coming up. So it's fine if the child is all right and you send the child home. After 12 hours, the child will come with severe shock. So the first episode of such allergies, ideally, you should keep the child in even after treating with any of these 3 drugs, and monitor the child for a secondary late phase symptom. Foreign body is the other reason why we usually see children in the emergencies. This is a 1 rupee coin. And as you can see in the lateral X-ray, it is behind the upper airway. So it is actually in the esophagus. This was presented to the emergency in a 3-year-old child recently. And with the help of a gastroscope, we were able to take the coin out. Of course, it may not be so simple. You may have various things being ingested: batteries, plugs, toys, Lego, all of these, needles sometimes. I mean, even had that, and we require a much more complicated assessment over there. And we need to try to ensure that we can safely remove the foreign object. But of course, with inputs from various specialties, for example, we may require a respiratory physician to do a bronchoscopy if it has moved into the airway, or we need a gastroenterologist or a pediatric surgeon to look down the other end, which is the esophageal and the GI tract. Battery ingestion is now becoming very common because we have these cute little CR2032 batteries, which are lithium batteries. The problem is in the gastric juice, they corrode and they may create lithium toxicity or may have even perforations coming in. So it is very important that the moment we have a history, we tag the battery in the GI tract. If it's in the upper GI tract, it becomes a bit easier to just do a scopy and remove the battery before it degenerates in there. Of course, many a times you find it is after 2 or 3 days, the child comes with abdominal pain and the battery has moved down into the mid gut or the lower gut, then it does become a challenge. Very rarely you need to go in and operate on the child because many times the intestine tends to perforate if the battery has been there for more than 48 hours. So we do try to look at things and try to get the battery out as soon as possible. Trauma is the other thing. So the reasons for trauma can be accidental, like fall from the bed, fall while bicycling, crush injuries in cars, injuries during games and recreation. You may have stumps being impaled into the foot, or you may have a ball hitting the eye. Multiple reasons for trauma. Driving injuries is another thing. So we take it depending on the type of trauma. As long as we are aware of the trauma, we need to be also aware as to what steps we need to take care. For example, X-rays, sonographies. If an infant gets hit on the head, then probably a sonography can rule out other issues. You may not always do an X-ray, but if you have a trauma child with unconsciousness, then obviously the child will go for neuroimaging in the form of a CT. It will pick up fractures like pond fractures also, or any intracranial, subdural or subarachnoid bleed, which then needs to be sorted out further. Driving injuries become important because in India, we have this fun fact of the father putting the child in the front seat along with him in the driver's seat and then trying to drive, suddenly braking. The child does not have a seat belt, and obviously the father's weight completely crushes the child. So it is very important that we now start understanding the implications of safe driving and keeping a child safe. This is a beautiful article in one of the newspapers, which using foreign features and scenarios actually suggested that we need to be very careful as to how we travel with the child in the car or even an infant in the car. So that is something we need to be careful. Before I end, I just need to show a couple of slides on what are the normal vital parameters, because once you know what is normal, it becomes easy to look at the abnormal and then refer at the right time or take the appropriate steps at the right time. So we have heart rate, respiratory rate, and blood pressure with temperature. So usually the heart rate is a bit higher in newborns and infants, but any heart rate beyond 116 in infant, beyond 130 in a toddler, beyond 110 in a child up to 12 years or beyond 105 is concerning and definitely should be looked into the cause for the same. Same goes for respiratory rates. Anything more than 60 in a newborn or an infant is concerning. Anything more than 30 in older infants or 20 in an older child would definitely require intervention. And blood pressure also follows something similar. So all of these are important because if I have a baby whose heart rate is 150, we need not panic and say this child is tachycardic. So it's age appropriate set of vital parameters, which I think we should roughly understand and know where we are going. Is that my last slide? So this is fine. We can. So whenever we have a child coming with any emergency, we need to first look at the level of consciousness. We need to look at the breathing. Does the child require any support or is the child comfortable breathing? And we need to look at the color of the child. Any of these are abnormal, definitely we need to intervene very, very fast. And when we do a primary assessment, we look at airway, breathing, circulation, which is any ABC for any newborn, infant, child, or adult. But we also look at the level of consciousness and what are the possible exposure which has led to this child coming to the emergency with something serious. So with that, I will stop. Thank you very much.
Thank you very much, sir. I understand this was a very vast topic and you covered it very excellent presentation, I should say. There are, I can see just one question, sir. Breastfeeding advised for early neonate who has a jaundice, mildly responding to phototherapy.
So whatever be the situation, jaundice is something where one needs to understand. The more we feed, actually, we reduce the incidence of jaundice. So if a child is on phototherapy, whether it's mild or moderate jaundice, as long as the child is neurologically normal, we would advise regular breastfeeding. So we do interrupt phototherapy once in every 2 hours and allow the baby to be cuddled and breastfed by the mother on a very regular basis.
Sir, can you throw some light on pediatric COVID management?
Okay, so pediatric COVID, 2 parts, newborns and older children. The exposure in newborns, of course, usually should be the mother. Transplacental spread, though not confirmed, there have been scattered incidences where newborns have come positive in the first 24 hours itself. So there is a possibility that the mother would be transmitting COVID down to the newborn. In older children, of course, it is all of us, whether it's child to child, whether it's adult to child, the same system which affects the adults. On an average, we find that children tend to behave much better as compared to adults when exposed to and infected with COVID. So we've had now at our facilities at NSCI and at Seven Hills, we've had admissions for children with COVID, but none of them, with God's grace, the 25 or 28 of them, none of them have required supplemental oxygen, have not required anything beyond symptomatic treatment. Having said that, that is for acute COVID. Unfortunately, there is a separate factor which is known as MISC, multisystem inflammatory syndrome in children post-COVID. So this usually occurs anywhere between 2 weeks to 3 months post-exposure to COVID, where it's an autoimmune reaction similar to Kawasaki's disease, where of course these children then become very unwell. They present with high-grade fever, rash, red tongues, severely congested lips, cracked lips, congested conjunctiva, will have a rash and are very unwell. So these are the ones who need to be evaluated because the single most important organ over here involved is sorry. So in these cases, we need to diagnose the MISC and we need to treat with steroid and immunoglobulin.
Dr. Howard, please mute yourself.
Yeah.
So that aspect of post-COVID syndrome in children is very concerning, and obviously we are on the lookout for this, and we have treated a couple of children with that.
Okay. Your take on COVID vaccination in pediatrics?
So
The last
scientifically, so I mean, there are multiple issues here. First of all, on an average, one needs to understand in the past, vaccines have taken anywhere between 5 to 7 years to prove the efficacy and safety. That is one. Second is, contrary to that, we've never had a situation of such an acute uh, uh, disaster facing us that we have started to cut corners. So even for adult vaccines, within 7 months, we were already there with the first vaccine. We've had a share of side effects, but then I look at it this way. We are today talking about survival. We are talking about survival, and we know that despite multiple research going on in treatment of COVID, we have not been able to label any one medicine which will prevent or treat COVID. Everything is in the proposed state. So as of today, officially, I can say we do not have any medicine which prevents or treats COVID. So hence, looking at these two factors, I think vaccination forms a very, very important pillar to at least reduce the intensity of COVID. And we know that happens in adults. There are sufficient studies to suggest that even vaccinated adults, if they get COVID, it's a very mild version. So that is good for us. Now, if we extrapolate that to the pediatric population, I do believe that we are in a severe need, because when we say vaccination in India, we are actually removing 35% of the population, which is the pediatric population. So from 1.7 billion, you're only talking about 1 billion. What about the 70 million children who are around? So at least I think, luckily, there have been studies going on, and we believe that at least 12 years onwards, there will be vaccination, as in bracket S plural, available to us September onwards. And probably most of the children should be offered vaccination by February 2022. Below 12 years is going to be the challenge. But then the killed vaccine, if I look at the killed whole vaccine, many of our vaccines are based on that technology. So I think they would be applicable. They have milder side effects. They may not be 100% efficacious, but I think we are not looking at prevention. We are looking at reducing the intensity of COVID. So overall, everything points out that we do require pediatric vaccination. Only thing is, how soon can science provide a minimal platform to say that it is relatively safe in children and offered to them.
Thank you, sir.
Thank you very
Thank you
much.
very
It
much,
was a
sir.
pleasure, and
Yeah.
thank you to IMA and all the dignitaries over here to allow me to talk for some time with you all. Yeah, thank you.
It was pleasure listening to you, sir.
My pleasure too.
Anil, any question?
No. We can move on to next lecture.
Okay, thank you so much,
Thank you.
Dr.
Thank
Rahul
you.
Verma, for giving excellent information about the pediatric emergency.
Thank
Now
you.
we'll move to the next speaker, Dr. Kiran Sathe. Dr. Kiran P. Sathe is a consultant for pediatric nephrology and general pediatrics at Sir H.N. Reliance Foundation Hospital and Research Center. He has completed his MBBS, DCH, DNB Pediatrics. He has completed research fellowship in pediatrics from Jaslok Hospital, Mumbai. He has received fellowships in pediatrics nephrology from the Indian Society of Pediatric Nephrology. He received clinical fellowship in pediatric nephrology from Bhai Jarbai Wadia Hospital for Children, Mumbai, and National University Hospital, Singapore. He also did visiting fellowship in pediatric nephrology from St. John's Medical College Hospital, Bangalore, Heidelberg University Hospital, Germany, and Children's Medical Center, University of Texas, Southwest Medical Center, Dallas, Texas, USA. He has been as a pediatrician and pediatric nephrology at Aditya Birla Memorial Hospital, Pune. He has also been received many awards throughout his illustrious career. To name a few: Best Clinical Research Fellowship Award by Amar Gandhi Foundation and Jaslok Hospital, Best Oral Paper and from Indian Society of Organ Transplantations and Pharmacon, J.N. Tata Endowment Scholarship for International Medical Education, etc. He has been invited as a speaker in many national and international conferences. He has multiple publications in index national and international journals and has taken an active interest in academic teaching. He is a pediatric faculty for online postgraduate coaching series, Dr. Mentor. His areas of special interest are general pediatrics, nephrology, critical care nephrology, pediatric acute and chronic renal failure, and pediatric dialysis. Today he will be speaking on common pediatric kidney problems in general practice. Over to Dr. Kiran Sathe. Dr. Kiran Sathe. Anil?
Yeah, he's there. He's connecting with some other.
Okay.
So can I request you? I think there is some internet problem. I'm just trying to reconnect with my laptop.
Yes,
Can
yes.
I start sharing my slides? Then I can.
Yeah. We can see you, sir. There are 2 more places we can see you.
Yeah. Can you see my slides, sir?
Slides not seen.
Okay. Because I can have started sharing. Can I request you to upload my slides, which I had
Yeah.
Are you still not able to see my slides?
Are you not able to see my slides?
Yes, now we can see.
Yeah, we can see your slides.
And for giving me to present this forum. And sometime I had a presentation on NCCs and dialysis and transplant in any person who has reversible disease. So in and those conditions where we
voice is cracking.
We pick properly in time and hello.
Your voice is cracking, sir.
You're not.
We are not able to hear.
Madam, are you able to hear me now?
Yeah.
Madam, hear me now?
But still there is a lot of disturbances.
Yeah. Oh. So we
Piyush.
So I think
the presentation मी सुद्धा मेल केलंय ते जरा ग्रुपला सेव्ह कर आहे का शेअर कर.
Hello. Yeah, sir. I think will you share my slides? Because
yes,
are you able to see now?
Yeah, we can see the screen.
I think now. Okay. Oh yeah, I think we'll press. Okay.
Recording in progress.
Hello.
Hello.
Dr. Kiran, I request you to turn off the other device as it will use more bandwidth. So I am sharing your presentation.
Just a second. Yeah.
So now are you
going to project?
Hello.
Yes, we are hearing you, sir.
Okay. Fine. So can I request you to change the slide, because I think I'm not able to change it from my side. Okay. So we will focus on children, and we will try to see those conditions which affect the kidneys of the children, so that if we pick them in time, we would prevent these children from progressing to chronic kidney disease and would save them from all the requirement of dialysis and transplantation. So what is peculiar about the kidney diseases in children is that over the past few decades, we have been able to increasingly detect and diagnose many of these kidney diseases which affect children. And this has been possible basically because of the increased awareness that even children can develop kidney diseases. And there have been also some improved diagnostic facilities which are available to us to pick up these kidney diseases in children. Notably is the antenatal ultrasound, which now helps us to pick up many of these congenital defects affecting the developing kidneys. And in addition to that, there are biochemical tests, dipsticks, which help us in making a rapid diagnosis of simple things like a UTI. As against, we also have genetic tests which now can confirm many of these genetically mediated kidney diseases in children. So a peculiar thing about kidney diseases is that in children, they often present with minimal symptoms, and the child may just present with fever, recurrent on and off fever. And if we do not suspect any kidney disease or a urinary tract infection, we would be entirely missing these conditions in the initial stages. And we may find these children come later with an advanced chronic kidney disease where it is usually a progressive disease, and ultimately the child would reach a stage of a chronic kidney disease, stage 5, or end stage renal disease. So there have been many cases which go unnoticed because we are not initially alerted that this could be a kidney disease in this child. The child. So we are in the formative years of the life when the child is still developing, and such kidney diseases will have significant impact on the other organs as well. Now, it is important to note that the kidney development occurs, starts very early in life.
Maybe that is by mistake.
And these kidneys, by the time the child is born, the kidney development has almost completed, and almost every child will have 1 million nephrons in each kidney. If due to certain reason this process of normal kidney development is hampered and if it gets affected, then the child will be having a compromised set of nephrons to deal with for his entire life. And that is going to put stress on him for the later years, and he will usually develop kidney dysfunction later in life. So even after birth, the kidney function will continue to mature, and until 3 to 4 years of age, the kidneys will still keep developing. So it is very important that these are the formative years when we have to be very careful about what medicines we are giving to the child, whether it has any adverse effect on the kidney function, and we have to take care of all these things. Can we go to the next slide? Yeah. So there are certain common conditions in our day-to-day practice that we encounter, and these could put the developing kidneys at risk for developing kidney dysfunction. So common conditions like dehydration, any child who comes with repeated vomiting, loose motions, and with a severe dehydration, the kidneys could secondarily be affected, and there could be acute renal insufficiency or acute kidney injury, which is the new term for acute renal failure. So this could be a simple scenario where the kidneys could get affected. Similarly, common drugs that we give to these children to treat fevers or pains, so something like non-steroidal anti-inflammatory drugs or certain antibiotics, which can also affect the kidneys significantly. And hence, we have to be very careful while selecting drugs. And if there is an alternative, we have to select the drugs which are least nephrotoxic. So simple things like paracetamol, instead of giving ibuprofen or Meftal, would be a better medication to give for such children to prevent kidney dysfunction. Similarly, during infections like pneumonias or diarrheas or any other infections occurring in the body, the kidney could get secondarily affected and can develop dysfunction. We are finding kidney stones now in a significant proportion of children, primarily because of the faulty diet, high salt intake, and low fluid intake. And if this stone remains there for a long time, it leads to obstruction to the kidney flow, and it can ultimately result in recurrent infections and can also damage the kidneys in the long term. Similarly, other rare diseases like glomerulonephritis, which are usually immune-mediated diseases, they also primarily affect the kidneys and can lead to long-term kidney dysfunction. So these are the common scenarios in our office practice. Then when we find these scenarios, we should be alerted that we have to think of the kidneys and at least do a basic evaluation to see is the kidney getting affected. So please, next slide. Yeah. So apart from these common conditions, there could be certain other conditions which can also put these developing kidneys at risk. So prematurity or being born before time is one such condition which could affect the nephron endowment. We just saw in the previous slide that the kidney development occurs in the first, second, and the third trimester. And if the child is born before term, before 36 weeks, then the child will have a less number of nephrons in each of his kidney. And this will be the final number of nephrons that he will have to live with for his entire life. And so this will put an additional stress on the existing nephrons, and usually they will have renal dysfunction in the later life that will be commonly seen. Similarly, diet, malnutrition. So malnutrition, when we speak, it is not just undernutrition, which we were commonly referring to in the initial years, but now even pediatric obesity is commonly seen in even in Indian children. And if we don't pay attention in the initial years, many of these children develop hypertension and kidney disease just because of the obesity per se. So these are other subtle risk factors which can put these children at risk for developing kidney disease. Another concerning thing is that delayed toilet training or prolonged use of diapers. Now, I think we find in many cases that the children, even up to 3 to 4 years of age, continue to wear diapers. That is basically for this convenience purpose, so that in the night they don't have to change the nappies that often. But what has been happening is that because of the prolonged use of diapers, the age of toilet training has been advancing. And we routinely find many of these children developing bladder dysfunction, continued bedwetting, and recurrent infections. And ultimately, these could be the children who could develop subtle kidney dysfunction or kidney damage in the long term. Similarly, drug abuse by the mothers during pregnancy in the antenatal period, if they are casually consuming drugs like painkillers or certain antibiotics, or if there is a administration of certain antihypertensives like ACE inhibitors or enalapril, these can adversely affect the developing kidneys, and it can completely alter the normal nephrogenesis. And the neonates which are born will have abnormal kidneys and will develop renal failure later in life. So I think these are the all the areas which we should be paying attention to, and we should take proper preventive measures in time. Yeah, please next slide. Yeah. So as we see that in all these scenarios which jeopardize the normal nephrogenesis, the child will be born with a reduced set of nephrons, and over time, it will put an additional burden on the kidneys to continue the metabolic demands of the body. And over time, there will be tubular dysfunction, glomerular dysfunction, and later it will lead to fibrosis in the kidneys, and a child would progress to chronic kidney disease and would develop all the morbidities which are associated with a chronic kidney disease like hypertension, anemia, bone disease, and all of these. So that's the importance of the preventive aspect comes here, that if we can identify all these things and prevent them for progressing to the later stages of chronic kidney disease, we can save all these harmful effects from developing. Yeah. Next slide, please. Yeah. So as we saw in the earlier discussion, kidney does not just produce urine, but has all the other functions also to take care of. For example, controlling the salt and the water content in the body, maintaining correct level of acid to prevent acidosis, maintaining normal blood pressure, hemoglobin, taking care of our bones and the heart, and ensuring that the child grows well and develops normally. So when a kidney is getting affected, all these things are going to get affected, and especially in a young child, his entire life is going to get transformed, and he will have a lot of morbidities and even mortality in very early life. So hence, we have to be very careful about all these harmful effects which can affect the kidney. Yeah. So next slide, please. Yeah. So as the primary provider, the physicians and the pediatricians are in the unique position to screen these children at a very early stage, because usually they will be the only point of contact for most of the families. And because of the enormous trust that they put in the physicians and the general pediatricians, it is our responsibility to screen all these children in time and to educate the parents to prevent any harmful habits which could affect the kidneys later on. So now we will come across a few common presentations in our office practice, which we can think of and tell the parents that these could be possible kidney diseases which could develop later. Next slide, please. Yeah. So the first common scenario is the antenatal presentation. Any pregnant lady during her pregnancy, if she does an ultrasound and if there are some abnormalities detected, for example, the commonest abnormality detected is a hydronephrosis or a dilated renal pelvis in the fetus. And if we find any such abnormalities, we have to take these things seriously. While many of these conditions would be transient, almost 50% would resolve by the time the child is born. but the remaining 50% would be persistent, and they would have some additional problems which we need to evaluate thoroughly and come to a diagnosis what kind of defect the child is having and try to resolve it as early as possible. For example, in the second picture, we can see this is a MCU, micturating cystourethrogram, of the same child who had a dilated bladder and a hydronephrosis in the first trimester. And when the mother continued to do the sonography and did the screening in the later trimesters, there was a persistent dilatation of the ureters. Bladder was dilated, and this child basically had a posterior urethral valve, as we can see. So after the child was born, the further evaluation was done, and it was confirmed that it is a posterior urethral valve. So this is one such surgical emergency which, if we do not pick up in time, it is usually going to completely damage the kidneys by the time the child is just few years old, and the child would eventually go to end-stage renal disease and would require dialysis and even transplantation. So this is such a simple thing that if we pick up on in time and do the evaluation immediately at birth, convince the parents that you have to do these investigations, then we can save all these harmful effects from developing. Next presentation, can we go to the next slide? Yeah. So the other common condition is the urinary tract infections, which is such a common condition that we treat in our office practice. A few things that we need to keep in mind is that urinary tract infections in children, especially young children, do not present with renal symptoms. So the child may just come with prolonged fever or unexplained fever or non-localizing fever. So unlike viral infections where the child would have cough, cold, some vomiting, loose motions, in a urinary tract infection, often we just find that the child has persistent fever and no other symptoms. So we have to be very careful whenever we have a fever in a young child. Urinary tract infection has to be one of the close differential that we have to suspect, and at least check a urine routine, check renal function in these children. And if we strongly suspect that there is a urinary tract infection, do a urine culture. So we should never be in a hurry to start antibiotics unless we have collected a culture. What happens if we just start antibiotics without collecting culture is that nowadays we have such a huge amount of drug resistance, and one drug which we have started may not work for that given child. And then if we have collected cultures later on, we would not even find the organism which is causing the UTI. And then this would be even a difficult situation to treat. The child would eventually develop chronic pyelonephritis, scars in his kidney, and would develop chronic kidney disease later on. These scarred tissues would eventually cause hypertension, and it could complicate the things further. So the take-home message for this kind of a urinary tract infection is that at least collect a urine for urine routine. If you are not able to wait till a culture to start antibiotic, simple things like dipsticks, which you could do in office practice. Now look for leukocyte esterase nitrite, check for the pyuria or the pus cells in the urine. And if you are strongly suspecting UTI, then at least collect a culture and then start antibiotics. So you may not wait for 48 hours to start antibiotics, but at least collect a culture. So this will be the first take-home message from this slide of a UTI. The next common scenario is a child who comes with red urine. So now red urine is a common symptom which directly tells us that this could be a kidney disease, whereas the other symptoms may not tell us that it could be a kidney disease. So red urine is a very alarming symptom that usually the parents are very concerned, and they're frightened that the child is passing red urine. So something significant would be there usually. So red urine has got many causes. It could be simple things like urinary stones or renal stones, which we could directly diagnose on ultrasound and then try to eliminate them by fluid therapy or by doing certain procedures. But it could be some other cause, which could be more serious cause like a glomerulonephritis, which could be resulting in a red urine. So when we find any child with red urine, it is important to do a thorough evaluation. Try to see if the child has proteinuria. So proteinuria with hematuria usually signifies that this is a glomerular or a significant kidney problem. And then this child should be referred to a pediatric nephrologist for a detailed evaluation, because these conditions are usually serious conditions and progressive conditions and need to be treated properly. Also do a kidney function in the form of BUN creatinine. And we may find very often that the creatinine is looking little elevated. And this could be a case of an acute kidney injury that the child has. So such children may require admission, stabilization, and then proper treatment after the assessment. Next slide. Can we have the next slide, please? Yeah. The other common condition which could be a telltale sign of a chronic kidney disease in these children is poor growth. Now, poor growth is such a common symptom and a common complaint with most of the parents that they usually complain that the child is not growing well or not eating well. And when they see the height or the weight, it is usually not expected growing as expected. So poor growth has got many causes, some benign and some serious. So benign conditions like nutritional deficiencies, if the child is not eating well, that could be the common cause of poor growth. But if you have given additional nutritional supplements, if you have given dietary advice, and even after a couple of months, if the child comes with the same complaints that he has not been growing well, and if you especially are noting his growth parameters on a growth chart, that could tell you significantly, give enormous information about the pattern of the growth of the child. As we can see here, this child has not been growing well and he has been crossing centiles. So his growth is plateaued, and it's clear that this child has growth failure. So such kind of pattern of poor growth could alert us that there could be some organic cause of this poor growth. It could be a renal failure, chronic kidney disease, or it could be hormonal deficiencies, or some heart condition, or some chronic infections like a tuberculosis. So we have to evaluate these children properly and do a creatinine, BU, and at least some electrolytes blood gas, because there could be certain other conditions affecting kidney like a renal tubular acidosis or a tubular dysfunction, which could also come with poor growth. So I think the take-home message here is that whenever you see child who is not growing well, think that whether it could be a kidney disease and at least do a basic evaluation. And if you think that it is a kidney disease, refer to a pediatric nephrologist for further evaluation. Next slide, please. Yeah, unexplained or a persistent anemia, another very common symptom that usually find in children. Most of it could be because of the nutritional iron deficiency or folate or B12, megaloblastic anemia. But even after giving 2 to 3 months of hematinics, iron therapy, and ensuring that the children were compliant, if you still find a child is still anemic and he has got additional symptoms like poor urine or looking breathless or not growing well, then this could be a scenario of a kidney disease in a child. And we have to then evaluate them for a possible kidney disease, do a creatinine, BUN, few other tests. And if you find them abnormal, refer to a pediatric nephrologist for further evaluation. These children could have a chronic renal failure. They would have elevated creatinine, and they could be in a chronic kidney disease advanced stage 3 or stage 4, where usually they have even crossed the stage of reversibility. So this could be a telltale sign of an advanced kidney disease in a child. Next slide, please. Yeah. So bedwetting again is a very common symptom that we find in many children. And while it may be common in the initial years, if a child has a bedwetting beyond 5 years of age, that should alert us that there could be something abnormal. While it could be just a transient physiological delay in maturation, which eventually settles down, there could be a subset of children where they could have serious kidney problems, like chronic kidney disease or renal failure, or they could have some hormonal deficiencies like diabetes insipidus or a tubular dysfunction, or they could have some bladder bowel dysfunction, so like overactive bladder or something to do with a bladder dysfunction. So I think when you are convinced that this is not looking like a simple bedwetting, I think again we need to evaluate these children by doing few basic tests like a urine routine, ultrasound, kidney function, and again you may have to refer them for a advanced screening to a pediatric nephrologist. Next slide, please. Yeah, rickets or bony deformities. So any child who has got rickets, it may not just be a nutritional rickets like a vitamin D. So it is a not a very good habit to just continue giving vitamin D, because vitamin D given in a toxic doses or if given inappropriately without testing can lead to kidney damage, can cause nephrosclerosis, and it can cause stones in the kidneys, and these could damage the kidneys in the long term. So when you are sure that this is the child is not responding to a routine vitamin D therapy, and this looks more than a simple vitamin D deficiency, it could be a chronic renal failure, again chronic kidney disease, or it could be a hypophosphatemic rickets or any other kind of resistant rickets. So these children again need a thorough evaluation, and one should refer to a pediatric nephrologist for evaluation. Next slide, please. Yeah, so other common things that we already discussed, some drugs which we often given to these children for treating fever or pain could have adverse effect on these developing kidneys, and they could very well develop acute kidney injury. The creatinine may rise, and they may lead to even chronic kidney disease. Especially when you give antibiotics like aminoglycosides or vancomycin when they are not required, I think we have to keep monitoring the renal function at least and make sure that it's not getting affected. Another serious condition is traditional medications, which we often find these things given to children just to promote normal growth or development. And while we think that they are usually benign, do not cause problems, we have had instances where these children had heavy metal poisoning and they came with renal failure, required kidney biopsy and dialysis. And there have been instances where these children could develop, even neurodevelopmental problems like autism. So I think these things should not be taken lightly, and one has to be very careful while giving any kind of drug to these young children. Next slide, please. Renal stones, I think we are seeing it very common now in young children, especially because of the inadequate fluid intake or very high salt in the diet. Chips, wafers, all these like faulty habits which they are usually having. So we need to educate the parents and ensure that we do not lead to all these harmful conditions. Next slide. Yeah. So as we discussed earlier, we were just debating about undernutrition in India, but now the obesity pandemic has affected Indian children as well. And in various studies, we are finding that up to 4 to 10% of these school children who are obese also develop adverse effects related to obesity in form of hypertension and heart disease or even kidney disease. So it is not just an entirely benign condition that we can be happy about. It could be a potentially serious condition, and hence we also must educate the children and the parents, especially to prevent these harmful eating habits and try to adopt a more healthy kind of a lifestyle and healthy habits of eating and living. It is also important to emphasize the need for a blood pressure checkup even in the young children, especially after 3 years of age, on an annual basis. So at least once in a year, even those children who are about 3 years should have their annual blood pressure checked with an appropriate cuff and make sure that these blood pressures are normal. And this would help us to pick up these 10% of children which could be having high blood pressure even in a very early life. And why is it so important? Because these hypertension in the childhood period is usually found to be associated with later onset of cardiac disease in the adolescents, young adults, even in 40s and 50s. So if we can pick up these young hypertensives, we can definitely advise them some lifestyle changes, even start on some antihypertensive drugs and then control this hypertension and prevent these heart attacks and strokes from developing later in the life. So it is our responsibility to educate the parents to make sure that the blood pressure is checked at least once a year. Yeah, next slide, please. So when we suspect all these conditions, it would be important to support them with a basic physical examination, even in a busy routine practice. It would take just few minutes to assess the height of a child by recording a height on a properly recorded scale. Take a weight of the child on at least on a regular basis and plot it on a growth chart. Check the hydration, look for edema, anemia of a child as we saw. Assess for avoiding and stooling patterns, especially if the child has any constipations or overactive bladder or bedwetting. It could be a bladder bowel dysfunction. Take a blood pressure, auscultate for the heart, see for the bones if the child has got any rickets. Do not forget to look at the spine. There could be a tuft of hair or some kind of a spinal dysraphism where the child could develop a neurogenic bladder and chronic kidney disease later on. Genitalia, especially for a phimosis, tight phimosis, meatal stenosis, where the child could have difficulty in passing urine. It could be a poor urine stream and could lead to recurrent urinary infections and long-term problems. Also, abdominal palpation for any lump would be important to look for any obstructed kidneys. Next slide, please. So after you have done a basic history and physical examination, when you suspect that there could be a renal disease, simple lab test which could be easily offered to the children in the form of a BUN, creatinine, electrolytes, blood gas, urine analysis, and if required, a urine culture. Again, urine culture should not be done when it is not required, not just when you suspect UTI, do not straight away do a urine culture. Because if it is not a UTI, it would invariably grow some of the other organism, and then it becomes even more confusing to justify this urine culture report, and we fall in a trap of treating the report more than the child, and then the child continues to be on antibiotics for a prolonged period of time. So do not do a urine culture straight away. Only if you suspect that the child has a urine UTI based on the urine analysis or CBC which shows a leukocytosis, only then do a culture. And this culture should be done properly. Midstream collection after cleaning the genitals should be advised. Otherwise, it could lead to contamination and can give us erroneous results. A renal ultrasound, as we saw, could pick up simple things like obstruction or a hydronephrosis, obstructed bladder, and it could tell us give us a wealth of information to guide us further in the evaluation of these children. Next slide, please. Yeah. So when we try to assess these children, these children could be falling into any of these 2 or 3 conditions. One could be a self-limiting condition, which is something like a UTI, which you treat properly, the child eventually recovers and there is no further sequelae to it if you detect it in time and treat it properly. If not, the children could land with acute kidney injury, as we saw glomerulonephritis or some nephrotoxicity, or some dehydration which has caused pre-renal kind of a renal failure, the children could come with acute kidney injury, elevated creatinine, and these children would require hospitalization, stabilization, giving fluids, and then do a specific evaluation and a treatment. Again, important caution is here is that we should not try to just look at the cutoffs, because in several labs that we get the tests done, the cutoffs are usually the adult cutoffs. So a creatinine of 1 may not be normal for a child who is 3 or 4 years of age. So I think we should be alerted to the normal cutoffs that we should be having for the pediatric population. So in children, we usually have creatinine something like 0.3, 0.4, 0.5, 0.6. So if you have a 0.8 or even 1 kind of a creatinine, it may not be normal for that given child. So I think you have to be alerted to the normal cutoffs which would be applicable to children and take things in the proper perspective. So if it is not an acute kidney injury, we could very well find a child who has a chronic kidney disease where the child does not have overt symptoms, but just poor growth, anemia, or some kind of rickets or hypertension. And then we have to evaluate these children. As we saw in the earlier discussion, eGFR is something that we calculate by a formula, and we try to find what stage of chronic kidney disease is the child belonging to. We also know that the chronic kidney disease usually progresses through stages. So we have stage 1 where it is a very mild kind of a disease where the child does not have many symptoms, but just some subtle abnormalities. And this is this stage where we should try to pick up and try to stabilize the child by giving proper lifestyle medications, lifestyle habits, a proper diet, and avoiding unnecessary medications, do regular monitoring, and then try to control the disease at this stage. But if it continues to progress, the child may continue to progress to an advanced stage and would eventually land into chronic kidney disease stage 5, where he would have a poor urine output, oliguria, severe hypertension, anemia, metabolic bone disease, acidosis. And at this stage, simple medications may not be able to sustain life. And these children would require eventually a renal replacement therapy in kind of a dialysis or even a transplantation. So our first aim should be to control the disease from progressing. So try to pick up at stage 1, stage 2, and try to stabilize at that stage itself. Try to prevent the progression. But if the child invariably progresses, unfortunately, to stage 5, where he eventually requires a renal replacement therapy, even those such therapies now are available in our setup, and we have in Sir H.N. Reliance Foundation Hospital availability for pediatric dialysis and even for renal transplantation in children. And it is our duty to educate the parents that one should not get afraid and should consult the proper people, maybe take an opinion of a pediatric nephrologist who can guide them properly about these therapies which could be required in time. Next slide, please. Yeah, so we saw about the dialysis. There are different options that are available even for children as young as even neonates or infants. So something like a peritoneal dialysis, which could be a very simple thing to do in these sick children, as against a hemodialysis, which could be a little more complicated, but would be required in certain conditions which are not getting treated just with a peritoneal dialysis. So if a child continues to require prolonged renal replacement therapy, if it is not an acute kidney injury, these children would eventually require a chronic dialysis or something like a renal transplantation, which could then be offered to these children. Next slide, please. So we saw in the first presentation that dialysis would be the best way to sustain life in these children who are very sick and would require to get rid of the excess fluid, salt, potassium, phosphate from the body. But then the better way than the dialysis would be a kidney transplantation, as we saw in Dr. Deshpande's presentation, that it has got many additional advantages which kidney dialysis may not offer. Especially in these young children who are at a very initial stage of their life, they have to attend to their school, continue their playing activities, have a normal healthy lifestyle just like any other child. So kidney transplantation, especially a preemptive kidney transplantation, would go in a long way to ensure that we offer the best possible life to these young children. And especially when you have made sure that this child has a chronic kidney disease, if the GFR goes to a stage below 15, we should counsel the parents that these children should be then considered candidates for kidney transplantation. And usually the parents, the mother or the father, or the grandparents or the uncles would be then the best donors for these children. And it has been proven beyond doubt that kidney transplantation is a safe procedure. So especially if each one of us has got 2 kidneys, and if a healthy donor after proper evaluation gives 1 kidney to these children, their life is going to get completely transformed. And we are going to prevent them from the evils of continued dialysis, going to the hospital 3 times in a week, missing school, missing activities, avoiding all the comorbidities and the developmental problems, the depression and all these anxiety, which usually these children develop once they are on a regular dialysis. So I think the take-home message here should be that we should not be afraid to counsel these parents that if a child requires a kind of a renal replacement therapy, we should be willing to offer them. At least go to a proper person who can give you a proper information and a proper center where such facilities could be offered to these children. So we at Sir H.N. Reliance Foundation Hospital are offering these chronic kidney disease management to these children and even dialysis and transplantation. So we would be definitely happy to help any of these children who eventually require any of these therapies. So I think with that, I would conclude the take-home message would be alerted to kidney disease in children, and at least in a busy practice, do a regular growth screening, at least a blood pressure monitoring once a year, and a growth assessment on a growth chart. And when you suspect, at least do a bedside evaluation, simple lab test, and then advise the parents accordingly. Thank you.
Thank you very much, sir. After that initial technical problem, we are. There are two questions I can see. Sir, your take on the use of steroids in peritonitis following nephrotic syndrome.
Yeah. So use of peritonitis and use of steroids in peritonitis. Yeah. Peritonitis basically is a condition which happens in nephrotic syndrome very commonly. It is called subacute bacterial peritonitis. And it happens usually because they are prone for developing infections with encapsulated organisms like pneumococci or Haemophilus influenza. So steroids, again, as we know, is a cornerstone of therapy in nephrotic syndrome. So we cannot do away without steroids, especially in a simple steroid-sensitive nephrotic syndrome. So when we encounter a child who develops peritonitis, usually the practice is that we would not start them on steroids straight away, especially if he has come in relapse. We would try to treat them with the appropriate antibiotics, initially IV antibiotics. We would admit these children, give them ceftriaxone or even penicillin group of drugs, treat the infection, and once we are sure that the infection is controlled, only then start on the steroids. So while it is important to give them steroids, it is important also to avoid steroids in these when they have come with a serious infection. Because at one point, if we do not treat the infection aggressively, and if we give steroids at that point, the infection is going to flare up and it can lead to even mortality in these children. So it is very important. Nephrotics are usually very fragile children. They have to be treated aggressively and promptly. We cannot leave it at a later stage because they can worsen within a couple of minutes or hours. So I think that would be an important message.
There is another question. If cyst is present at the birth, what is the approach and further management?
So can you repeat the question?
If cyst is present at the birth, what is the approach and further management? I think you must be talking of renal cyst or something.
Yeah. So renal cyst is again a common finding that we find in the ultrasounds when we do even before birth or after birth. So if it is found before birth and if there are multiple cysts, it could be very well a condition of a polycystic kidney disease, which normally we find even in certain young neonates or infants or even in the fetal period. Especially if there is a family history, even if either of the parent has got a cyst in the kidneys, and if they have developed hypertension or a kidney disease later on, third or fourth decade, then this could very well be related to the cyst in the developing fetus, and it could be a scenario of a polycystic kidney disease. As against that, it could be a simple scenario like a simple cyst, which could not be a part of a polycystic kidney disease. So the first thing would be to take a proper guidance, take a proper refer them to a proper person who can guide them properly. Otherwise, they could get afraid, unnecessary anxiety, unnecessary test. So many of these children would initially not have many symptoms. We would just monitor them on ultrasound, do a growth assessment, do a blood pressure, check urine protein. It is usually in the third or fourth decade that they usually develop complications if it is a polycystic kidney. Now, there are genetic tests which are available to confirm whether this is a polycystic kidney, which we could also offer to the selected case of subset of children. Not to all of them if we are sure that it is a polycystic kidney. But if it is a simple cyst, we would not do unnecessary tests and would not unnecessarily panic these parents, because then it would lead to a lot of anxiety in their minds. So I think best way would be to refer them to a pediatric nephrologist who can tell them, give more additional information and can counsel all their anxiety and counsel them properly.
Thank you very much, Dr. Sathe. Excellent presentation.
Thank you very
Can I
much.
ask one question?
Yes, yes.
Yeah, no. Yeah.
What is the minimal age for pediatric age for kidney transplant?
Yeah. So in India, what has been usually found is that 10 kg and above is usually the stage where these children can suitably transplanted, because that is a stage where the adult kidneys or the donor kidneys can be safely transplanted in their small tummies. Right? So that 10 kg and above would be a safe cutoff. In Western nations, they are even doing in the neonatal or the infancy, but in our situation, it is a 10 kg and above. So around 1 to 2 years would be that stage when they would reach that stage for a possible kidney transplantation.
Okay.
Thank you so much.
Thank you very much for the opportunity once again. Thank you.
Thank you so much, Dr. Kiran Sathe, for giving excellent information about the pediatric kidney problems in general practice. Now we'll move to the last speaker, Dr. Ravi Gupta. He's an interventional cardiologist. I request IMA President-elect, Dr. Anil Awad, to introduce the speaker. Dr. Anil Awad.
Yeah.
Yeah.
Dr. Ravi Gupta is the senior consultant of interventional cardiology at New Age Wockhardt Hospital, Mumbai Central. He did his graduation from SMS Medical College, Jaipur, followed by MD in internal medicine from RNT Medical College, Udaipur. He then did his DNB in cardiology from Escort Heart Institute and Research Center, New Delhi. He is a fellow of American College of Cardiology and the Society of Cardiovascular Angiography and Interventions. He has performed more than 6,000 coronary angioplasties, including the most complex cases like left main, CTO, and bifurcations. His areas of expertise and interest include interventional cardiology, non-invasive cardiac procedures, pacemaker implantation, coronary intervention, peripheral intervention, device implantation, and ASD-BSD closure. He was selected for Best Young Interventional Cardiologist in India in the year 2009 and 2011. He was honored with prestigious Rajasthan Gaurav Award in the year 2016. He has multiple national and international publications and has been invited to chair several international conferences like TCT. And I'll add one more, that he is a very good artist and he's a very good painter. You can see his paintings on his Facebook account. Sorry to include maybe a non-medical thing, but I should appreciate his art. Over to Dr. Ravi Gupta. He'll be talking to us coronary and beyond.
Dr. Awad, doctors are always multi-talented, and so the other talents should always be highlighted,
Yes.
It's so sweet of you, Dr. Awad sir, for your kind introduction and sharing something which, I mean, on academic forum, normally we don't do.
Yeah.
So this is what, I mean, I'm blessed to be here. Thank you very much for IMA Mumbai to inviting me here. And what I would say that if you love your profession and you love your profession in a way that if you combine your hobby with this, probably you can do better. Like what I would say, when I do a complex coronary intervention, or for that matter, any intervention, I would imagine that how I can make the arteries look beautiful. I mean, probably a non-artist would never understand that how can arteries look beautiful. So this is what I imagine that, I mean, I would run after even small branches to make the carina of the arteries looking good and all those things. So this is, I'm going to speak today, and I hope you can see my slides and you can hear me properly. Yeah, perfect. I hope I'm clear.
Yes, yes.
Very much.
Yeah. So today, whatever time you have allotted me, I will try to summarize in another next 20 minutes or so. That this is my brief introduction, which Dr. Awad sir has given me very aptly. That this is my introduction. I primarily worked in Delhi for almost 15 years. That time Escorts used to be the biggest institute. So I started working there. And for a while I was in US and I learned peripheral interventions there. So I was able to understand the peripheral interventions. And now we deal a lot of diabetic foot ulcers also with a lot of complex interventions. So what I would share gracefully that all these cases which I am showing, these all cases were performed here only, and these all are complex cases. So how do we define complex cases? I mean, whenever we talk about coronary interventions, one is simple intervention, second is complex. So complex would be, in general, you can say, if you are doing a unprotected left main angioplasty, if you are doing a chronic total occlusion, it means these are old blockages with very hard to cross the wire across it. At times we take hours together to cross those wires. And when you are dealing with the main artery and the branch, so we call it bifurcation lesions. So bifurcation means you are dealing with, for an example, a diagonal and a main LAD. And we have a series of trifurcation also. I mean, when you are dealing three arteries together, for an example, a left main is divided into LAD, a big ramus, and a circumflex, or an early OM. So these are trifurcation cases, and we have series of trifurcation also here. And when we call high-risk cases, which may be severe LV dysfunction, patient may be so sick for any surgical procedure, maybe badly asthmatic, maybe chronic kidney disease, or a large subset of patients which we see, these are not willing for bypass surgery. So these are the coronary cases. And when we talk beyond, I would say peripheral arterial disease, as I told that this is my area of interest. So we have been doing not only the lower limb arteries, but we treat the arteries of the carotid arteries, the mesenteric arteries. We treat the subclavian artery also if patient is planned for a surgery and the subclavian artery is diseased, so the surgeon would get the benefit of lima. So we fix that subclavian artery also by a stent. Upper limb CTOs we open when the ulcers are not healing, and so on. Renal arteries are, of course, a very routine thing which we do. Another less talked about issues like erectile dysfunction, what interventionists can do in erectile dysfunction. This I'm going to discuss in one small slide. TAVI we have been doing routinely. I mean, changing the aortic valve without surgery. That is another thing. TAVR, we did yesterday also one case of AAA, aortic aneurysm, abdominal aortic aneurysm, endovascular stent graft. IVC filters in the pulmonary embolism patients, because these patients mostly have deep vein thrombosis and the thrombus in the lower leg veins, and they are very prone to move this thrombus to the pulmonary circulation. And we fix an IVC filter or umbrella-like device just below the renal arteries, so the clot doesn't move to the pulmonary circulation. Then, of course, non-surgical closure of holes in the heart. We do all type of congenital abnormalities like ASDs, VSDs, PDAs, coact, and all those things. And another interesting thing which I will share is alcohol septal ablation in HOCM. These are hypertrophic obstructive cardiomyopathy patients. I will spare one or two slides on HOCM patients. And of course, pacemakers, we all know it's a routine thing, single chambers, dual chambers. When patient and history of VT, then we put ICD. And when the heart pumping is very low, no other reversible cause, left bundle branch block, then we'll put CRT, cardiac resynchronization therapy, with or without a defibrillator. So first I'm going to show, I'm very gracefully sharing these all are, I would say that these all patients were sick patients, not ready for surgery, clearly surgical cases, not ready for surgery at all, or very, very high risk for surgery. So first patient is 78-year-old male. I mean, I have just handpicked few cases. So this has disabling angina. He is not relieved even with the maximum anti-anginal dose. He was advised for CABG 6 years back, for which he denied. So this time again, he came with failure and chest pain. We stabilized him, and we knew that the disease must have progressed by now. So this was the disease. You can see that my catheter is in the left main, and right coronary artery is getting filled from the contralateral side. It means we know that right coronary artery is 100% occluded, which is getting the collateral supply. This is LAD, all diffusely disease. If we see different views, you can see that the left main looks okay, but there is a big ramus arising and a big circumflex, which has also very tight disease. So we tried to convince him this was the right coronary artery, which was almost 100% occluded. So we tried to convince him for surgery. Of course, he was not willing. So we planned to go for a surgery. Whenever I touch a left main, I will make sure that I fix the right coronary artery first. Because when we balloon in the left main, we practically occlude the circulation of the LAD and circumflex together. So these patients can crash if you haven't saved the right circulation. So first we opened the RCA CTO, and this was reasonably good result. So we plan to go for this LAD trifurcation. You can see that there are 3 wires in the LAD diagonal, LAD ramus and circumflex, and we dilate one by one all of them. Once we achieve a good dilatation, then we take 2 stents. You can see 1 stent in the LAD starting right from the left main. Luckily, in this case, the left main is quite petulous. So we were able to start right from the distal part of the left main. At times we have to come across the left main, but in this case, you can easily see that I have started 1 stent from the left main distal part covering the LAD and another stent in the ramus. We deploy these stents together, and then yeah, you can see that now the flow in LAD after removing the balloons, you can see the very nice flow in LAD and diagonal. And then this circumflex, this is the 3rd stent, again ending into the left main. We do kissing in all 3 arteries. I mean, there are 2 ways. We can do trissing also. Trissing means you are taking 3 balloons together, 1 in LAD, 1 in ramus, and 3rd in circumflex. In this case, as the left main was quite big, so we could manage with bifurcation, only kissing only. So once we are putting 2 balloons in the circumflex and ramus, and another time we are putting 2 balloons in LAD and ramus. So this was what we have been doing, and this was our final result. So angiographically, it looks very fine, and I always suggest that whenever we are dealing with the left main, we should always do some imaging. So none of my case which we have done a complex intervention, we use any imaging, either OCT or IVUS. So this case also demonstrated nice result with OCT. Similar case, 65-year-old male, he came with multiple fractures in the right lower limb, underwent multiple surgeries, and very slowly started walking with a stick. And believe me, the patient was not walking brisk, but still he could make out that he develops chest heaviness even with the minimal activity. We did his ECG. ECG was normal. 2D echo was also normal, but the pain was so typical. Sorry. So I had to advise him for coronary angio, and he was a sensible person, so he agreed to that. And this was his angiogram. You see that the left main looks healthy, but just the distal part of the left main is grossly diseased. The ostium of the circumflex has a tight disease. The ostium of the ramus is also tight disease, and the LAD ostium is also very tight. And this is the right coronary artery. You can see the right coronary artery is more or less normal. This is the RV branch. This is the RV branch. So we concentrate on the left system. This is how we started. And in this view, you can probably make out that the circumflex ostium is very, very tight, and it is calcified also. So we put 3 wires in all 3 arteries. And in this case, as the patient was sick and I wanted to be more, I wanted to play more safe. So I put an intra-aortic balloon pump also. You can see this part, this is an intra-aortic balloon pump, which is giving us a external support. This is a transient support for the sick patients. So this we are putting a stent in LAD, and while putting the stent in LAD, I remove the wires of circumflex and ramus, because at times these wires are get stuck between the lumen wall and the stent. Then it becomes another difficult situation. But once you do this, then you have to be, skillful enough that you can recross the wire through the stent struts. So once we put a stent from left main to LAD, then we recross wire in the ramus and the circumflex, and this time I take 2 stents, and this is how we are deploying these stents. After deploying this, we do a lot of proximal kissing, the same fashion which we have done earlier in the earlier case. And this you can see that we were very lucky in this case that the ostia of the LAD and this ostia of the ramus and circumflex, these are slightly away from each other. And whenever we do kissing, ultimately we do pot. So we make the left main again circular with a small but big size balloon. This is what we have been doing. And after that, this was my final result. Again, we confirmed with our OCT and we were happy. Third case is very interesting actually. Normally what happens that the common thinking earlier, when we started intervention, I would say almost 20 years back, that time left main used to be like a surgical disease. If you have a left main disease, even a slightest disease, you are not supposed to touch it, send it across to surgeon. That used to be the thought that time. Over the time, the hardware becomes so user-friendly, and now I would say that even the young people who are working in the peripheral centers, they are also doing very good job because of the availability and the concrete data suggesting that we can do a lot of complex cases without surgical intervention. So this patient is again a 30-year-old male, EF is 35%, not at all willing for surgery. So this was his anatomy. This anatomy is different from all we have seen. You can see a tubular left main, and which is absolutely healthy, and a disease in the ramus, as if the continuation of ramus is left main. This looks like a continuation. This is LAD and this is circumflex. So we have a different plan for this patient. In his case, what we did, we plan to put a stent from left main to ramus. Normally, we put one stent from left main to LAD and then take other branches, other arteries, ramus or circumflex as branches. But in this case, we took ramus as continuation of LAD of left main. So this is what I did. I did the first stent, then recrossing the wires through the struts into the LAD and then to the circumflex, recrossed, put a stent, and we make sure that just one strut of the stent comes inside the body of the main stent, so it doesn't leave the lesion. At the same time, much metal also doesn't come inside the main stent. So you have to be very cautious when placing a stent of this situation. We are happy with this. Then similar fashion, we do LCX stenting, and finally we do final kissing with non-compliant balloons, and these were our final results. So this is all. I just wanted to show a few trifurcation cases, and this is a retrograde PCI. Retrograde PCI means you are entering either in the left system from the right system, or you are entering the right system from the left system. In this case, what happened that this patient, I did his left main to LAD plasty, and we planned for this what is filling late, this is right coronary artery, and this right coronary artery is actually being filled from the left artery, and you can see that a very tortuous, you can see actually these are two tortuous septal arteries which are attaching to the right coronary artery. So our plan was to enter in the LAD, then into the septal, then we enter into the right coronary artery. This is known as retrograde PCI. So you can see that my wire is going in the septal artery. The LAD goes this way. My wire goes, this is a very, I would say, floppy wire. So these are very soft wire which takes the course of the arterial tortuosity, and we are able to manage to take the wire here. But what happens once you reach the CTO distal end, then you need a hard wire. So you need to change this wire over a small, very thin, soft microcatheter. So you exchange with a microcatheter, then you change with your hider wire. This takes hours actually, but this was the final result. We could able to achieve or cross the lesion in RCA. Once we balloon it, then we put an antegrade wire, then we stent it. So the end result was happy, and actually I did this case as a live case. So this was again a lot of adrenaline relief on that day. But at the end of the day, we could do it. This is another case which has gained a lot of popularity, transcatheter aortic valve implantation, which we also do routinely here. Normally, aortic valve replacement is a surgical disease, but over the time, we have learned that we can replace the aortic valve without surgical method also. So this is one example case which we did here. When we enter in aorta, this is a young patient. He has a dissection of the aorta here. And this patient, this dissection was actually, we found a flap, which was detected in our CT. And the patient was a young male. So we didn't want to take any risk that if this flap increased, the patient would die. So we took a self-expanding stent. I think you can see there is a stent. I'm pulling out my balloon and the stent is getting implanted. Only thing, challenge in this case, that the error, margin of error was very less. I mean, I need to start just after the renal arteries, and I must finish my stent before the bifurcation. So just as a landmark, you can see a thin wire. This is a coronary wire, which I placed from, sorry, from one iliac to the another iliac. So it is giving me a landmark that my stent should finish before that. And by choosing the appropriate size, we could achieve that. The patient is doing absolutely fine. Yeah, this is another interesting case. This is one example, but we have been doing almost, I would say, almost 10 complex peripheral angioplasties in a month. So this patient came with a non-healing ulcer. I'm sorry. So what happens, whatever dressing, whatever you do, but till you don't open those arteries, this wound is not going to heal. Another request, or I mean, I'm just thinking loudly, that some patient would think that amputation is the answer. Amputation without opening the artery is also not an answer, because when the surgeon cuts the limb, he needs a flap, and this flap has to be healthy. So if the flap doesn't have a good blood supply, it is not going to heal. So this is one case where you can see that this is the knee, and you can see there are 3 arteries. This is a popliteal artery, which divides into anterior tibial, peroneal artery, and the posterior tibial artery. The artery on the medial side is the posterior tibial artery. You can see this is 100% occluded. Peroneal is also 100% occluded, and this anterior tibial is very diffusely diseased. So it becomes a difficult job to cross these old hard blockages. I hope you can see that with a loop, we are able to enter into the artery, and then we are ballooning it. Similar fashion, we are entering in the anterior tibial artery. You can see a balloon being inflated, a lot of calcium, which is giving difficulty to the balloon to open, but ultimately we are able to open those arteries. So now you can see that all three arteries, right from the leg, this is the mid part of the leg, and this is the foot. So once you achieve this type of circulation, you are very confident that now your surgeon can also do the best of his expertise. And this, we need to make the patient and the relatives understand. Sometimes they would think that if the amputation is, has to be done, then why to open the arteries? But this is the reason that we have to open the arteries. Pacemakers for fast rate ICDs, whenever the heart rate goes very high, we all doctors, we understand that VT and VF, these are the rhythms which are life-threatening, and patient needs to be shocked immediately. But every time patient cannot be lucky. Patient gets VT, within 3 minutes, his brain circulation will go. So if we have some way to put the machine inside, that smart machine will detect the abnormal rhythm and shock on its own. So this is ICD which we do. We make something like pacemaker only. We put a small device under the chest. This all is in local anesthesia. Cardiac resynchronization therapy. This is also very tricky. You can see that the normal contraction of the heart, this is the left ventricle. When the left or the lateral wall is moving inside, the septum should move inside. This is how, a symmetrical or synchronous contraction of the LV is required. Whenever a patient has left frontal branch block, this contraction becomes dysynchronous. It means when the septum is coming inside, the lateral wall is also going outside. So these are not contributing in the contraction of the left ventricle, which is very important. So in CRT, what we do, we put one lead in the RA, one lead into the right ventricle, and third lead in the coronary sinus. So which takes care of the left ventricle contraction. And this is how we do. You can see this lead in RA, right atrium. This is a defibrillate, which will defibrillate also if it is required. And you can see a third lead. It is in the coronary sinus. Erectile function. This is one thing which I have been treating for almost 15 years now, but still the awareness about erectile dysfunction and what we can do is not very, very clear. Initially, people used to think that 90% of erectile dysfunction is psychological and 10% is some which we can help. But over the time, people have learned that actually 10% is psychological and 90% is that which can be treated. So what would happen? We need to understand that atherosclerosis is a generalized process. It can happen anywhere. If somebody has blockage in the coronary arteries, he can blockages in the carotid arteries also. He can have a stroke also. He can have blockage in the renal arteries, so he can have uncontrolled hypertension. Similarly, if he have blockage in the peripheral arteries, he can have peripheral arterial disease. Similarly, the arteries of the penile area, internal pudendal artery, these also can have blockages, and those have diabetes or evidence of blockages anywhere else, or patients are chronic smokers. These patients have high chances of having erectile dysfunction. And this is the reason. In this case, you can see my catheter in the common iliac, and this is the internal iliac artery, and you can see a tight stenosis here. The internal iliac artery has two trunks, anterior and the posterior trunk, and the anterior trunk has a branch which is known as internal pudendal artery. So once you find these are reasonably big size arteries, so you just balloon it, stent it as we treat the coronaries, and you have a very good flow. And what is the logic of doing this behind this? That I'm going to discuss in the next slide. That this problem is a common problem, but because of the shyness or because of the taboo, people don't discuss this problem. Another thing, vascular is primarily the cause behind it. We need to remember our basic physiology behind a male organ erection, that it needs a gush of blood multiple times to make the organ erect. If somebody has a blockages supplying that part, the internal pudendal artery or proximal part of the internal leg artery, it means the blood flow is not reaching. If you are opening that blood flow, then the gush will occur and this start working in a normal way. So we have data of a few patients, and those are doing, wonderfully well. And they were actually at times discussed very patiently and very gracefully that they were not aware of that this problem can be treated ever. So this is one thing I just wanted to share, that we do internal pudendal artery angioplasty also, and it is very helpful. Another issue, this is probably my last 2-3 slides, alcohol septal ablation in HOCM. Hypertrophic obstructive cardiomyopathy is a situation when the left ventricle wall is thick and the septum is thick to the extent that it is actually obstructing the outflow of the left ventricle. This is the basic physiology or basic pathology of the hypertrophic obstructive cardiomyopathy. And we know that if we find a big septal artery which is supplying the septum, if we occlude that artery, the blood supply to the septum will start decreasing, and this septum will start thinning over the time, and the gradient will decrease and the problem will be solved. Another option for HOCM patients was myomectomy. But believe me, myomectomy used to be a very, very crude procedure in which the surgeon actually literally used to shave the interventricular septum, and even with best of the centers in the world, the results are very, very bad. So the people don't opt any surgery for HOCM. So we are left with maximum dose of beta blockers, but still if the gradients are high, then what you can do? Then what we do, that we selectively enter a septal branch and inject alcohol, 100% alcohol inside the septal artery, and create a heart attack inside the cath lab. This is what a simple diagram showing. You can see that this is the posterior wall and this is the septum. This septum is quite thick. Even in this way you can make out the septum is quite thick. So we just by angio we detect, and this is you detect that this artery is supplying the septum. We inject alcohol and we make sure that the muscle gets shrink. This is a small video I gracefully share. One of my patients, this is an international patient, and she also underwent alcohol septal ablation, and this alcohol actually really worked. So you just see, and probably you will enjoy her singing. She says, "You saved my life." So this is the alcohol actually worked for this very sweet lady, and she has been doing absolutely fine. She keeps on calling me from her country. She's from Zimbabwe. So the take home, I would very gracefully conclude my lecture. The patients and relatives, whenever we are dealing with these complex cases, they should understand that we are dealing with primarily surgical cases. If they are not willing for surgery, or if the patients are not fit for surgery. Sorry? Yeah, I'm about to finish. Yeah. So the complexity and the roadmap should be very clear, not only to the primary operator, but to the whole team. I mean, it's a team effort. When we are talking about the trifurcations, these are very, very uncommonly performed cases. I mean, even if I show these cases abroad, trifurcations are very, very uncommon to perform. We need to understand that the angles between, you have to be imaginary. As Dr. Awad sir told me in the beginning, that I'm an artist. So I imagine that what beautiful I can make with these arteries, just imagining that I will place one stent from left main to LAD and then this and this. So this is how I try to imagine and then try to prove it on table. These all patients and are, performed in Wockhardt Hospital here only. I'm not showing any of my previous data. These all patients are very dear and respectable to me. So I am not disclosing their identities except Maggie Mafosa. Maggie Mafosa, who is a darling patient, and she did a very sweet dance, and you could make out, you saved my life, Dr. Gupta. So it was so sweet. So I thought that I must share it with all my dear friends here in Mumbai. And this is all I wanted to say. Thank you very much for your patient listening.
Sir, can you show your paintings, some of your paintings?
I'm sorry, I don't have on my laptop. So, I mean, I don't know how can I share. I mean, probably I would share it to Dr. Awad, and then love to share with you all. So thank you very much for giving me an opportunity to interact with you all. And if you have any queries, please let me know.
There are no questions. I cannot see any question because I think people are to run.
Run for Raksha Bandhan.
That's good for me. Actually, I always, my last slide is that any questions, and I hate questions. So. So I'm happy with this, and good interacting with you all, and it was very nicely organized.
Dr. Kajal?
Sure. Thank you so much, Dr. Ravi Gupta.
Thank you
for giving a wonderful information about the interventional cardiology, coronary and beyond. Now the last ceremony of the function, I request Assistant Secretary, CGP Sub-Faculty, Dr. Kajal Ahuja, to give a vote of thanks.
Good afternoon, all. I would like to thank our speakers of today's webinar, namely Dr. Puneet Jain, Dr. Richa Bansal, Dr. Rushi Deshpande, Dr. Kiran P. Sathe, Dr. Rahul Verma, and Dr. Ravi Gupta. I also thank our knowledge partners for the day, which are the Apollo Hospital, Sanofi Healthcare India Private Limited, Sir H.N. Reliance Hospital, and Wockhardt Hospital. I thank Mehta, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiSheet, who have given us the platform for the webinar and handled all the technical details at the same time. Thanks to Dr. Anil Awad and Dr. Usha Shah for conducting this webinar smoothly and efficiently. A big thank you to Pragji Vada for being the NMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success.
Thank you, Dr. Kajal.
Thank you.
And thank you all my...
Have a nice
Thank
Raksha
you.
Bandhan day. Enjoy the Raksha Bandhan ceremonies.
Nice
Yes,
party.
yes,
Okay,
yes.
take care.
So thank you all panel doctor and speakers.
Bye.
Bye. Yeah.
Bye.
Piyush.